surgeons from around the world to teach us and bring us up to date to 2020. And what will be an exciting component to this is that each of the instructors has also prepared at the end of their segment either a clinical pearl or a case that has given them personally a refractive surprise, and how do they manage such a thing. The format of the forum will be alternating between lecture and multiple choice. So in the time frame that we have, we may not be able to get through the entire topic, as you can imagine, but the idea is that whatever we do cover, that you are able to cement it in your mind, in your brains, as you prepare for boards or as you go back into your clinical practices post-COVID, and take something from this that can help you along the way. So I thank you again for taking the time to be here. Our first session will be by Dr. William Trattler. Now, Dr. William Trattler is the president of the American European Congress of Ophthalmic Surgery. An esteemed refractive surgeon, he has participated in over 70 clinical trials and has written hundreds of articles, both peer and non-peer reviewed, focused on cross-linking keratoconus, cataract surgery, multifocal IOLs, LASIK, laser vision correction, and dry eye. He's the author of the very famous Microbiology Made Ridiculously Simple, which, Bill, that was a staple in my medical school, as well as Review of Ophthalmology. I still, treasure that book till to date. He was on the executive board of the International Society of Refractive Surgery for more than 8 years and is currently on the executive board for the Refractive Surgery Alliance for the past 5 years. We have quite a few Refractive Surgery Alliance members as well with us today from different countries, so welcome. Without further ado, I hand it over to Dr. William Trattler for our inaugural lecture, Unraveling the Mysteries in Refractive Surgery.
Thank you, Ashiyana, and thank you. It's great to see everybody. It's kind of fun in these Zoom calls to see all the different backgrounds, and I noticed the best one so far is George Waring. He has a nice little world. He's outside of this world. He's really, that's probably the best way to avoid, COVID-19 is to be on the space station. I like that. So we'll start. I know we have a lot of content to go through, so I'll jump right into our talk. My talk is meant to be a little interactive, so during the time I may call on some of the faculty members to help. My talk is entitled "Unraveling the Mysteries in Refractive Surgery," but there's mysteries, but there's a lot of things that we know, and we'll go through all those fun things. Again, this is an incredible group of refractive surgeons from across the globe. And again, George outside of the globe, but it's an incredible group of faculty members. I feel really lucky to be here with everyone overall. This is our program. I'm sure you guys know the program, but looking forward to listening to everyone else's talks as well. So this overall presentation will really focus on all of refractive surgery. It's kind of an overview talk, but just point out laser corneal refractive surgery. I'm not sure how many people were around in the 90s and stuff like that in ophthalmology. It was just when I was finishing my residency and fellowship that corneal refractive surgery, specifically laser refractive surgery, really got started. And now we have so many great technologies. We have Smile, with LASIK, we have wavefront optimized, and we have wavefront like eye design, which is even more advanced. We have topography guided ablations with both LASIK and then PRK. And PRK in particular has changed so much over the years, and especially the epithelial removal techniques, and we're having really great results with that technology as well. So I think of just the overview of refractive surgery. I think that some of the main procedures we're working with are LASIK, PRK, Smile, ICL, and refractive lens exchange. There are some outdated procedures that aren't really used anymore, but some people are still using them. So for example, conductive keratoplasty, there may be a role for keratoconus. Some people may be using that. Intacs for myopia Intacs were developed for myopia back in the 90s, but now it's used for keratoconus. And corneal inlays are still used in parts and pockets of the world, but they're not quite as popular as they were a few years ago. Then there's some very old procedures which were before my time, including ALK and LTK. Sure, I remember that. Oh, and don't forget to put yourself on mute if you're you know, just listening and stuff. Anyway, so one of the things we've learned is that not every patient is a good candidate for laser corneal refractive surgery. So patients come in, they're thinking of you know, having LASIK, because everyone knows the word LASIK, and they come in, but they're really not a good candidate. It could be because of their refractive error, they're too myopic or too hyperopic, they could be too old or too young. The corneal shape, like in this image here, can be abnormal. They may have an early cataract or even a real cataract. They could have severe dry eye. And of course, patient expectations. There's so many situations where patients aren't good candidates, and we all have to be very good at identifying the good candidates and also, you know, identifying who's not a good candidate. And then also, you know, we can switch people from LASIK to, you know, ICL or refractive lens exchange, which has grown over time. Now, this is a really nice slide that was put together by Lance Kugler, and it's not a perfect, you know, presentation because, but the idea is that if you look at the refractive error in the left bar and the age below on the bottom, you can see that at different age points, we might be using different procedures for the exact same refractive error. So if someone's a -4, you know, and they're 18 years old, you know, we're going to consider PRK, LASIK, and SMILE, for example. Actually, I guess SMILE they put at age 21 because of the FDA approval, but maybe off-label you might consider it. But you know, if you get into the higher levels, you might start to consider ICL as an option, depending on various you know, reasons. To, you know, maybe the corneal shape makes the patient not a good candidate for ICL. So I hope it's helpful here. This little, you know, and it is available online to review this. But you know, and then as patients get older, we're going to start thinking more about refractive lens exchange. And really, you know, I used to do laser vision on older and older patients, but that's really dropped. So typically, you know, my age for doing PRK and LASIK has really dropped over the years, where I'm thinking more refractive lens exchange. Thanks to some great work by a lot of people, including George Waring. And then we have cataract surgery, which is really refractive surgery. You know, it's covered in the United States by Medicare or by insurance. We often will make it into a refractive procedure. So let's just use a challenging case. This is one of these difficult cases where there may not be a perfect answer, but you have a patient who's a mild myope, a little bit of astigmatism, and they love kite surfing. So they like to be active and outdoors. And so it's really difficult for them to wear contact lenses. This is their corneal thickness. This is from the Pentacam, and you can see that they have, you know, very nice thick corneas, you know, 561 and 563 essentially. And we even have this I guess little thing from the Pentacam, which is called the percentage thickness increase, which is really pretty normal for this patient overall. And when this parameter gets abnormal, the red line will go below the three dashed lines. So it's kind of still in the normal range. They're just showing you the high end of normal, low end normal. So this is coming out as far as normal, and Renato Ambrosio helped develop this parameter looking for early keratoconus. So this patient, quite interesting, and this is their topography. So who wants to jump in first and tell me what they think of this topography? Ashiyana, do you want to call on somebody?
Yeah,
like
sure. We have Wyatt Messenger. Wyatt, would you like to give a stab at this?
Sure. Yeah. There's looks like there's inferior steepening that would suggest like a keratoconus or some type of ectatic disease.
Absolutely. So yes. So thanks for sharing. So you can see it's a little asymmetric. There's a little bit of a skew of the axis, but it's not, you know, a huge amount. I mean, the scale is actually very tight here. So scale is a very important parameter for evaluating, you know, for looking at a topography. So it is like we're looking really, really closely versus like, we're not where George Waring is outer space looking down on the Rocky Mountains. We're like on a helicopter looking just above the peak. So we're looking very closely. So you can see like the top part is in the 41, 42 range in the right eye and gets down to 44. So there's definitely asymmetry. And it's not quite regular. So I guess the point being here is the patient, she's really anxious. She really wants to have refractive surgery so she can do her hobby. Low myopia, corneal thickness is normal, suspicious topography. And she really can't wear contacts when she's doing certain activities. So, you know, the question is this early keratoconus or not? And then does she have a refractive surgery option? I don't know, should we call on Karolinne? Or Ashiyana, who do you want to call on?
Yeah, perfect. Karolinne, will you chime in? If she's there. Otherwise, Christine Shea, are you on the line? Christine?
Hi, sorry, can you repeat the question again?
Of course. Okay, so we put together this patient, 32 years old. They have all these parameters. They have this interesting corneal shape. Question is, can they have any type of refractive surgery so they can actually do their sport? You could also say this is a person who's a police officer or fireman that is worried about wearing contact lenses on duty, and they just really need to try to eliminate their need for some type of glasses or contact lenses.
I think you could consider PRK. I'd want to also see some of the other pentacam imaging as well before making that decision, but I think that could be a consideration.
Excellent, excellent. And
Bill, it's
excellent.
Karolinne.
Yes.
Sorry, because I had some connection here issues. I was on mute, but I think again, tomography is really important here, right? I want to look at elevation maps. Question here: any issues with dry eye or masquerade syndrome that can be causing like this irregular stigmatism, right? Definitely this is a patient with irregular stigmatism. So we, again, need to rule out all the causes of irregular stigmatism first. And I would look at elevation maps. I would be a little, if this is real and this is someone that, with some other changes, sometimes ICL can be a good option.
Bill,
Yes,
the posterior, just the pachymetry map is abnormal because the thinnest point is dragged a little bit inferiorly. I guess you'll probably show us the pentacam to show us that, but it looks dragged inferiorly, so the posterior surface doesn't look normal.
Yeah, it's not quite normal. So this is a patient that I agree is at some level of early keratoconus. Some irregularity, there may be a little bit of dry eye, still not completely knocked out. And so I guess with this degree of early keratoconus, again, the patient, is like, what are the options? I mean, so this is kind of the list I put together, but they can certainly consider cross-linking and then wait a year or two when the cornea is stronger, and then consider PRK. You can have PRK with close follow-up, and then crossing if there's any signs of ectasia that develops. You can combine the PRK and crossing, which I'm not a fan of, but some people can do. Of course, you can say no surgery. The patient is a little low for, in the US, there's no ICL for the level of myopia, so that really wouldn't be an option for them, although that would be an option if the patient was more myopic. So everyone gave great answers, and obviously we could also look at epithelial mapping, which I didn't have for this patient. But just these are all things to consider. Again, lots of mysteries, no right answers. Just want to share that case. So clearly, we're going to have a talk coming up on topography coming up. But obviously, topography is one of the key things, and it can disqualify patients from corneal refractive surgery. But they might still end up being a candidate for a different procedure. And then we're going to talk about topography in just a few minutes, placido disc and tomography. And I'll just jump through that. And then one thing to remember with placido disc is that you can have dropout when it's very, very steep. The placido disc can't quite capture steep corneas. And then again, sorry if I'm jumping too much into topography, but obviously we're going to look at different patterns between keratoconus and pellucid. And then here, this is more of an early case of keratoconus, just mild changes, but steep cornea. This is a patient with a skewed axis and some inferior steepening. So these are all little pros to look at. So, and then we have a patient like this. So, Ashiyana, do you want to call on someone to say what they see in this one?
Yeah, absolutely. Why don't we call on Sonal Shah? Sonal Shah, will you give us your input on this case? Or if not, we have my resident on the line, Shruti Jeswal. Shruti, will you give your input on what is the diagnosis? Okay. Or Padmini. Padmini, will you give us your input? Okay, well, Bill, you'll have to teach us because they're
no worries. Yeah, and it's when people are mute. That's a challenge. People are muting, so that they don't like make So I understand it takes a little while to get back in. But you can see here, there's a little superior steepening in both eyes. and the K's are a little steeper superiorly versus inferiorly. I did not have epithelial mapping, and I'm really excited to start to get involved in that to see if this is just an epithelial hyperplasia or thickness causing this, or this is truly superior, like a superior keratoconus. So for now, I kind of put superior form fruits keratoconus. We're not certain, but in these type of cases for corneal refractive surgery, I'd still not consider smaller LASIK unless I had epithelial mapping to prove it was there was epithelial thickening, but I might still consider PRK. So after myopic LASIK, we expect to see a nice round circular flat ablation zone. And you can see here that the blue area is where it's flattened following laser vision correction or LASIK PRK, and you can see the same thing with SMILE. And then you have this red rim, and it could be just a higher, steeper area peripherally. That's myopic LASIK. And then hyperopic LASIK is the exact opposite, steep in the center. So just to make sure we're aware of that. And then when we get to patients coming in for refractive surgery consultations, and you see this, I guess the answer is, what is this? Why is it so abnormal? And are you calling Dr. Wu, maybe, Helen?
Dr. Wu, give us your expertise.
So it looks like this person is steep in both, well, sort of centrally in the left eye and inferiorly, and steep superiorly and centrally on the right eye. I don't know if they're, did you say they came in for a consultation, or they already had hyperopic
Yeah, they're coming in for consultation. So they're coming in for a consultation for either cataract surgery, refractive lens exchange, or LASIK. So where we get a preoperative topography.
Yeah, it's pretty irregular. So I would want to treat the surface and repeat that.
Absolutely. And so what Dr. Wu is noticing is that there's these little areas here which are dry spots, and this is what the cornea look like. And so when you have a cornea that looks like has this amount of staining, you're going to get these really funny irregular shapes on the topography overall. And anyway, so just to again be when the topography looks abnormal, be very suspicious for dry eye and treat dry eye, and often you get things looking better. Here's another patient. It came in for corneal refractive surgery. And you can see here that this looks pretty much like keratoconus with inferior steeping in both eyes. But they had a really rapid tear breakup time. They had corneal staining. Oh my God, where's it? And then it turned out that when we, I apologize, missing the next slide. But typically what I'll do is I'll treat them for 3 or 4 weeks, bring them back, and the topographies do look better after treating them. So here's a case courtesy of Dr. Lowe, Jennifer Lowe. And this is one of the patients that came in. They had actually had myopic LASIK 20 years previously. They came in actually for cataract surgery. This is one of my, I don't know, for my title, the mysteries, or for, I guess, refractive surprise case. So maybe Dr. Waring, or actually, do you want to call anybody else, or?
Yeah, Dr. Waring, would you like to chime in on this one?
So the good thing about being such good friends with Dr. Trattler is I've gotten to see his many of his lectures before. So I think I've been called on this slide probably about 15 times throughout the years, which is not, so hopefully I get it right. Let's see. So now these can be tricky. And then there's 2 aspects of this topography to pay attention to. The first one is where you see the mid-peripheral steepening in the crescent in the inferior portion of the image. And so when you kind of first start doing LASIK and you see those can be of concern, but are all often a function of not centrating your treatment on the vertex of the cornea. And that's what happens when we treat on the pupil usually. So that's actually often normal. But what can be abnormal is this central inferior button that you see clearly in a myopic LASIK. Now, we don't know if they've had additional treatments or not, but that's when we really have to be suspicious for ectasia. And where you'd want to look at other information to try to confirm your diagnosis. So I'd be highly suspicious aphasia here. Now, of course, without a slit lamp exam, it could be epithelial ingrowth, it could be a scar, it could be any opacity, even, I mean, it can be anything. But let's just say it looked normal, then that's where I'd be worried about is post-LASIK ectasia.
Yeah, no, George, you did that beautifully, and you seem quite experienced at describing topography. So you're absolutely correct. This is an area, the slit lamp exam was completely normal. Nothing irregular. So actually, you wouldn't see this on slit lamp exam. The slit lamp exam looks normal, but on topography, Dr. Lowe saw this area of steepening. This is really a case of post-LASIK ectasia, just one of the earlier cases where you can just see this area of red or steepening coming in from the flat, what should be the flat ablation zone. So excellent description. Here's another case, and again, I put in some of these cases because Ashiyana wanted me to give some challenging cases. So this patient's interested in refractive outcome with cataract surgery. So again, cataract surgery is this kind of refractive surgery. They have just 0.91 diopters of astigmatism, but this is what the topography looks like. Hey, Ashiyana, do you want to call anybody or?
Who do we have here? Why don't we have Dr. Bala Ambati? Bala, would you like to give us your input on this case?
Hi, Bill. So there's a large area of steepening temporally. First question is that real? Is there any ocular surface disease or dry eye? Second question would be, is there some Salzmann's nodule vertically that could be causing a weird effect on the cornea? If it is real and there's nothing abnormal on the cornea, such as Salzmann's nodule or peripheral thinning, then I would not put in a toric lens on this patient. I would just tell this patient his surface is irregular and he may very well need glasses or contacts.
Absolutely. No, Bob, great description of the case. And so actually, on this particular case, you can actually see findings on slit lamp exam that kind of explain what this was. And this is what it looked like here. So the patient had EVMD. Again, this is an older patient. They wanted a refractive outcome. And so, in this situation, what needs to be done is an epithelial removal procedure. So we're going to remove the epithelium and smooth out the underlying cornea.
So Bill, a question came in for you on this particular case, that could this be because of a pterygium or an ulcer?
Yes, I mean, if the patient had a pterygium, you could see an area of steepening somewhat similar to this if it was kind of in that area. So that certainly could be a possibility. That's where the slit lamp exam, revealed that this was EBMD rather than a pterygium. And then a corneal ulcer, usually you're going to see flattening, not steepening. So it'll be the exact opposite. I guess you could have a central ulcer perhaps, but it wouldn't be quite as asymmetric typically. So, but if with a corneal ulcer, you just never, topography could be definitely irregular for quite a while. So that's always a possibility. So this is EBMD. They would do epithelial debridement, and I usually like to wait 3 to 4 months for the epithelium to remodel before remeasuring, because it does take a while for the epithelium to get back to baseline, and then being able to proceed with surgery. Okay. And I apologize, I don't know how my slides got out of order. I know George Waring's in outer space, and he must have maybe did some type of hex and switched it around. But this is that case from a couple of times ago where they came in looking a little suspicious for keratoconus. I treated their dry eye, and then now this is what they look like, 2.5 months after treatment with anti-inflammatory drops and plugs, where they're much less irregular. So I think just in general, and we're getting close to being done, because I know we have a lot of great speakers. Obviously, we're going to look and make sure we rule out keratoconus, pellucid, which I know Helen's going to go over more in her talk, very thin corneas, diffuse corneal dystrophy, HSV or history of HSV, dry eye, and we're going to evaluate all these parameters and figure out what your next steps are going to be. We want to avoid, make sure that there's no clinical signs of keratoconus on exam, perform Fruist, which typically with keratoconus, they can even be mild to moderate. In the corneal and the slit lamp exam will be normal. But if they do have some type of form fruits or some type of irregularity, typically you're going to want to, if you're going to do anything, you're going to consider PRK or ICL and avoid LASIK or SMILE. So I'll look at both eyes here. I just sharing one or two last things, which is just Marconi Santiago came up with this concept of percent tissue altered, which some people follow, some people don't, but just something to consider that, you know, that one risk factor for ectasia after LASIK or even after SMILE would be if you go too deep into the cornea. So he came up with this concept called percent tissue altered, PTA, and the idea is that you want to only impact the top 40% of the cornea, say less than that. So if the corneal thickness is 500 microns, 40% of that would be 200 microns, so you don't want to go below with your ablation depth combined with your LASIK flap thickness or SMILE depth, pocket depth, or PRK ablation depth below 300 microns. The bed should be 300 microns or more. Again, this is just going through the PTA, but I feel bad that I think I ran a little late. Okay, I guess this is the last case, which is a LASIK consultation. This is a tough one. This is actually provided by Ralph Chu and Jessica Heckman. But this is a case that they had, a 34-year-old male that came in. The question was, does this patient have keratoconus? And how do you rule out keratoconus or not in this patient?
So we're going to call on Bhakti Walawalkar. Bhakti, are you there?
Yes, doctor.
Okay, so how are you going to figure out if this patient has keratoconus or not? Like, what type of things are you going to look for?
Firstly, there is an inferior steepening and asymmetric bota in both the eyes. We can look at pachymetry to see for corneal thickness.
Excellent. No, that's pachymetry, of course, is very helpful to figure out if there's a very thin cornea or there's thinning that's asymmetric. This is the Kmax. So just showing you this. This is the patient's thinnest location was, still above 500 microns. They were somewhat steep, but not too steep in the 46 range, which is the Kmax. Mild myopia. But this is a really interesting case. So we also did what's called the D value, which is a technology that Dr. Boleyn and Dr. Ambrosio came up with to help us figure out, this patient was at risk, looking at the global pentacam values, if this patient's at increased risk for ectasia with LASIK, and so kind of fell into the normalish range. I see Dr. Khalif is concerned that the IS ratio is maybe abnormal. It's interesting that the pentacam, many of the technologies we have don't actually give us an IS ratio that we can look at. You can calculate it, but it's really difficult to calculate. You have to come up with 5 spots on the cornea, inferiorly and superiorly, at the 6-moment optical zone and try to mathematically calculate that. But the IS ratio is helpful, but I don't think it's being used all the time, but it's something to consider. So the question is whether epithelial mapping would help here. And what should an epithelial map reveal? Because this is a newer technology. And if we have keratoconus, we should see thinning over the apex if this is actually a case of early keratoconus. So just showing you some different examples of normal and keratoconus. In a normal eye, you'll get a little steepening, just a little bit more inferiorly, just because of the way the lids wipe against the cornea. But in keratoconus, you're going to have this area of thinning, of epithelial thinning over the cone. So the 2 middle images here are epithelial thickness maps or profiles of patients with keratoconus, and the normal ones are on either side. And you can see that there's going to be different patterns. And many people have used this map to figure out if people are appropriate candidates for laser vision correction. So you can see that Dan Reinstein had a paper where he looked at this, and if the patient had a normal, did not have epithelial signs of, or epithelial thickness map signs of keratoconus, he actually did LASIK on them, even if they had inferior steeping, like in this case. And so, and this is Dr. Ralph Chu and Jessica Heckman actually have 2 different methods of measuring epithelial mapping. One from Zeiss, and you can see here they have thick epithelium on the Zeiss map, and they also had the OptiView, same thing, this thickened epithelium over where that steepening is on the topography. So in actuality, this patient may not actually have keratoconus. They may have just epithelial hyperplasia, and they may actually be an appropriate candidate for LASIK or SMILE. I think we need more work in this area, but it is a really interesting concept to start to consider as we're trying to understand these patients better. So definitely I would think that PRK could be an option because they're low myelo, and even some doctors are even doing LASIK in these scenarios. I'm going to just skip this last case just because we went through a lot, but overall, you know, I hope this is a good overview of refractive surgery. I'm super excited to hear everyone else's, you know, excellent lectures on to further advance our understanding of refractive surgery.
Dr. Trattler, thank you so much for being our inaugural lecturer. It was fantastic, and it laid the foundation for all the lectures and multiple choice questions to come. So thank you for that. Next, we have with us Dr. Helen Wu. Dr. Helen Wu she was my medical school mentor, okay? And she was one of the reasons why I am an ophthalmologist today. Yes, I'm gonna go through her CV. She's assistant professor of ophthalmology at Tufts University School of Medicine. She was a senior editor for the Journal of Refractive Surgery. She has received numerable awards from the American Academy of Ophthalmology and so on. But I have to tell you, when I first went into her clinic, okay, she'll have 70 patients wait for her for hours together. And when she opens up her mouth, I don't know which language will come out next. She speaks German, Russian, Haitian, Creole, Chinese, not to mention English, but there's so many languages, and there's so much about this woman that has so much depth. And most importantly, the compassion that she has for her patients is something that I have yet not imbibed in my life, but I hope to one day, because she, for me, is an epitome of compassion when it comes to her patients. So without further ado, I'm greatly honored that Dr. Helen Wu has taken up Colors of the Rainbow, multiple choice questions on topography and tomography.
Thanks, Ashiyana. I appreciate the introduction, the kind introduction. So can you see my slides okay?
Yes, very good.
Okay. So I'm going to start off with an easy one if you want to pick somebody. Which technology produces corneal tomographic maps? Placido disc-based, Scheimpflug imaging, scanning slits, color LED point-to-point ray tracing, or anterior segment OCT, either B, C, and D, or B, C, and E. Which one?
Excellent. So we have with us Dr. Mónica Rojas Olivera from the Escuela Superior de Oftalmólogo Instituto de Barker. Dr. Mónica, will you please give us your best answer on this one? And also, if we can have Dr. Sylvia Casas, Dr. Juan Arbelez, and Dr. Wyatt Messenger, Dr. Christine Shea, all ready to go. So if Dr. Mónica may not be available for this one, can we have Dr. Sylvia Casas, cornea fellow from Columbia?
Yes, I know for sure Scheimpflug, and based on the fact that with Pentacam I do see an anterior segment OCT, I'm gonna guess G.
Yes. So the difference between topography and tomography is that topography only images the anterior surface, which are Placido disc-based and color LED point-to-point ray trace in the Cassini. So the other answer is Scheimpflug, scanning slits, which is orb scan, and anterior segment OCT. All are able to image both the front of the cornea and the back of the cornea, in addition to other anterior segment structures. So therefore, they are producing tomographic maps. So that is the difference between topography and tomography. Let's see. Let's go to the next one. Whoops. Oh, okay. Sorry about that. The corneal topographic maps are useful for all but screening and monitoring for refractive surgery, corneal ectasia screening, pre-op IOL selection, post-keratoplasty management, ocular surface disorder, and measurement of corneal hysteresis.
So we have Dr. Juan Arbeles, Associate Scientific Director from Muscat Eye Center, Oman. Dr. Juan, will you give us your input on this question? And if Dr. Juan's not available, we have Dr. Wyatt Messenger, University of Washington Cornea Fellow. Ah, Dr. Juan is there.
Hello. Can you hear me?
Yes, Dr. Juan.
Well, basically, corneal topography will be able to give us all the information of the anterior curvature of the eye. With corneal topography, unlike with corneal tomography, we will not be able to have information from the back surface. So it will be useful for screening and monitor a refractive surgery, not the ideal because we are missing the posterior curvature. We will be able to use it as a corneal ectasia screening also, but again, not the ideal instrument because we don't have information from the posterior curvature. Preoperative IOL selection, it could be useful also for deciding, but we will not have the total corneal power since we are missing the posterior curvature again. Post-keratoplastic astigmatism evaluation and management, also it could be useful. And for ocular surface disorder evaluation, of course, to measure the corneal hysteresis, I don't think is the best option because we are just having the anterior curvature of the eye and we don't have any information from the hysteresis with the topography maps.
That's great. And I should have probably put topographic and tomographic because these first 5 are best for that. It does not, none of these imaging devices or none of these actually measure function of the cornea, which is hysteresis. So let's go on to the next one. And this is a, let's say 64-year-old corneal transplant patient. And these are the placebo images here. Which of the following is true? This is an example of with the rule astigmatism. Sutures should be removed at 5 and 11 o'clock. Posterior corneal astigmatism can be measured with this technology. This patient has irregular corneal astigmatism. And in normalized without transplants, this type of astigmatism is more common in older patients.
Excellent. So we have with us Dr. Wyatt Messenger, who gave a little input earlier, University of Washington Cornea Fellow. Dr. Messenger, will you give us your best guess?
Yeah, so just looking at the placebo disc image, it looks like with the rule astigmatism, which is more common in older adults. So I'd go with E.
Okay. Actually, it's against the rule, astigmatism, and this type of astigmatism is more common in older patients.
Helen, can you show us the map again, just to make sure and kind of educate why you said it's that?
Sorry, I meant to say against the rule. It's at the steep meridians are at 0 and 180.
Yes. Yes.
Sorry,
good. And you can see here on the placebo image. No worries. That the lines are closer together, closer to the 3 and 9 o'clock positions, and sort of an oval shape and more drawn out towards the superior and inferior cornea.
And just a point on that, you know, I tell my residents a lot when we're doing keratoscope that to use those Myers to their advantage when it comes to PK suturing and figuring out which ones are tight, which ones are loose. So thank you for putting up that image.
So just a reminder that with the rule astigmatism is steep in the vertical meridian, more common in young patients, and against the rule astigmatism seen in the lower image is steep in the horizontal meridian and more common in older patients. The anterior cornea shifts from with the rule to against the rule astigmatism with aging. In a PK, you would take out sutures in the steep axes, so more at the 3 and 9 o'clock position. And if you were doing cataract surgery in the normal eye, you would put the toric lens horizontally in the previous case, or AKs or LRIs at the steep axes, which would be horizontal in that case. So this patient, on to the next question, is an 83-year-old woman who was operated on elsewhere. She had this degree of astigmatism, 1.75 diopters after surgery at axis 84, and she had a toric lens implant placed at axis 85. And postoperatively, she was very unhappy. She had 1 diopter of against the rule astigmatism on refraction, and the IOL was positioned properly at axis 85. So what happened here? What is the most likely reason? A, the simulated Ks from a placido disc device are inherently inaccurate compared to a Scheimpflug device. B, the effective lens position of the toric IOL differs between individuals. C, the posterior corneal astigmatism was not taken into account. And D, the toric lens was mislabeled and the wrong power lens implant was inadvertently implanted.
Okay, so we have with us Shruti Jaiswal. Shruti, are you on the line and are able to give us your best guess on this one?
I think it's C. Posterior corneal astigmatism was not taken.
Great. That's
so
excellent.
Proud of you. Shruti is my resident. So
Great
proud
job.
of you, Shruti.
Great job. All right, so a little word on posterior corneal astigmatism. The posterior cornea is a minus lens. On average, it has about half a diopter of against the rule astigmatism that does not change with age. So eyes with the rule astigmatism will need a lower power toric lens than the anterior curvature would suggest, and eyes with against the rule astigmatism will need a higher power toric lens than we would predict with our normal formulas. The Scheimpflug devices do not always accurately measure the posterior corneal astigmatism, and obviously the placido images never measure posterior corneal astigmatism. So Doug Koch, with his Baylor nomogram, incorporates this mean posterior corneal astigmatism and also the effect of aging on the anterior corneal surface and the against the rule drift. And this is the nomogram that Dr. Koch has published, and you can see here that you wouldn't start to put in a toric lens until you get until about 1.7 diopters of with the rule astigmatism, but you would put the lowest power one in as low as 0.4, 0.5 diopters against the rule. So here's another case. This is a 68-year-old gentleman who was very unhappy after his cataract surgery in the left eye, shown here. He had a monofocal lens implant placed. It was a perfect surgery. He wanted a toric lens implant in the right eye because he had such high astigmatism. And here is a topography of his right eye, topographic map. So he also had an anterior segment OCT, and you can see the findings similar to his shown here. So which of these statements is false? He should have a lens exchange with toric IOL in the left eye to 101 degrees and put in a toric lens implant in his right eye at axis 99. B, he has irregular astigmatism in both eyes. C, he may require superficial keratectomy prior to his intraocular surgery. D, his ocular condition may be associated with recurrent erosions in the past. And E, his condition may recur.
Okay, so we have with us Apurv Chebolo, University of Albany Medical Center resident, PGY2. Apurv, if you're there, can you give us your best guess on this question?
I guess C, maybe EB and D.
C, he guesses C.
Okay. Let's go on. The answer is doing any kind of toric lens in this patient. And the reason is that he has Saltzman's nodular degeneration. So let me just quickly flip back to this. So you can see here superior steepening. And this, in his case, by looking at the slit lamp examination, was clear. He had an opacity in his superior cornea. And when we look at his OCT findings, you can see here a very subtle opacity, subepithelial. And in this case, my thing is covering it here, but over here is an opacity that's elevated. And these are classic for Saltzman's nodules and cause irregular astigmatism. So he actually did have a history of recurrent erosions in the past. He had rosacea, and likely he had Saltzman's nodules because of these underlying conditions. So flictenulosis, rosacea, IK, trachoma, and actually LASIK is not an uncommon predisposing condition, and usually those are seen peripherally. Which of these may be associated with irregular corneal astigmatism? Dry eye, anterior basement membrane dystrophy, you already know that from what Bill said, exposure keratopathy, corneal scarring, and contact lens warpage, or all of the above.
Okay, so we have with us Dr. Amy Werner to give us, this will be our last question of the segment. So Amy, no pressure, but give us your best guess. Okay, and if not Amy, then we have with us cornea and refractive specialist, Dr. Basir Khan, Medical Director of Clarity Eye from Canada. Dr. Khan, will you give us your best guess on this question?
Yeah, all the above.
Good. This is dry eye. This is PUK, peripheral ulcerative keratitis and ulceration. And this is corneal warpage. Ashiyana, do I have time to just fast forward to one more slide, sort of one more?
Absolutely, absolutely.
Or am I at the end of my time?
Yeah, but absolutely.
Okay. I just want to go through because there was a question about this.
Yes.
So let me just go through. So there was a question about how to distinguish pellucid. So I want to ask about this question here. This is a high against the rule astigmatism. Should I ask this as a question or just tell you the answer?
Why don't you tell us the answer?
Okay. This is not a pellucid, even though it has against the rule astigmatism with the crab claw pattern. And you can see here that there is inferior corneal steepening, not in the periphery, but in the paracentral area. Now, there are obviously limitations with orb scan, but the answer here is actually keratoconus with a pellucid pattern. So Rizzuto's phenomenon is the one clinical sign that would go along with this condition. And I just want to point this out to the person who asked the question. So the way we know that it's pellucid marginal degeneration as opposed to keratoconus is looking at the slit lamp example, slit lamp for one. Also with pellucid, we see this beer belly side profile with this crescent-like shape inferior steepening, and it's very, very peripheral compared to keratoconus, which is paracentral. So that is keratoglobus. This is what we see in pellucid marginal, flattening of the vertical meridian and much more inferior steepening in this pattern. And this, I'll end with this. This is Dimitri Azar's paper. These are both pellucid patterns, but this is a classic pellucid on the left, whereas on the right, this is a keratoconus. And you can also see this pattern with LASIK-induced ectasia. So I'll end there.
Dr. Wu, thank you so much for that. And anyone that has questions for Dr. Trattler, Dr. Wu, you can message them directly or put it on the chat. Absolutely. Questions are most welcome. Thank you, Dr. Wu. So moving forward to Do You See? Optics and Aberrations by Dr. Shady Awwad. Now, Dr. Shady Awwad, anybody that does anything with regard to optics and aberrations, already we know their IQ is above X. But let me tell you a little bit about Dr. Shady Awwad. Dr. Shady Awwad is an associate professor of ophthalmology and the head of cornea and refractive surgery at the American University of Beirut Medical Center. He received his medical degree from the Alpha Omega Alpha Honor Medical Society and completed his residency at the American University of Beirut. He subsequently completed a fellowship in cornea and refractive surgery and then ocular pathology at the University of Texas Southwestern Medical Center. His research is focused on analytical corneal imaging, wavefront analysis, keratoconus diagnosis and treatment, IOL calculations, and refractive surgery. Without further ado, Dr. Shady Awwad, thank you so much for being with us today.
Thank you, Ashiyana. Thanks a lot. And it's an honor to be here. It's quite, it's a lot of fun. And, you know, it's nice to see something that is really geared to residents and to learning. I think we all learn in this common experience. So let me check. Okay, can you see my slides?
Yes.
Okay,
Beautiful.
perfect. Okay, so I'm going to talk about the basics of wavefront technology. I think most of the talks we always listen go a little bit further into the technological pattern and what we have here, but sometimes we miss the real basics of this technology. So I want to go back and discuss the basics of wavefront optics. So again, whenever we think about wavefront technology, wavefront optics, we think about the light as an electromagnetic wave and not as a ray of photons like we think of during or when applying geometrical optics. So if we look at a beam of light coming from infinity and we cross-section it in time, the same photons that are at the same time originating from the same source and they are in phase with each other will form a plane wavefront. If we have a point source of light and we cross-section that point source of light, we will end up with a spherical wavefront. All the photons of these spherical wavefront will be in phase and will be at the same time emanating at the same time from that point source. So imagine like people holding hands and walking at the same time. So whatever the shape changes, it's still the same wavefront because they're holding hands and they started from the same position. So any optical system is considered ideal if it focuses light in one single point. Of course, there's no such thing because of problems of diffraction and other things, but typically a system that suffers from optical aberration will not focus those lights into one point. And the difference between the ideal wavefront, in which here is in blue, and the aberrated wavefront will be the optical aberrations. And we always hear that term root mean square because it's expressed in root mean square. So what are root mean square? If you look at the ideal wavefront, and let's say it's black here and the aberrated, which is red, the small differences between them, if we sum them up, if we add them up, they might cancel out because some are positive, some are negative, some are delayed, some are actually forward. So a way to avoid that is to square these values and sum them up, then run the square root value of the square. So we end up with root mean square. And that's nothing but a standard deviation. So this is like looking at the standard deviation of the error of a wavefront. Now, of course, it's expressed in microns because it's in micrometer and it's not in millimeters. So it's in micrometer. Again, in ideal wavefront, as we saw here, in an ideal system should end up in focus in one point. But one of the problems of spherical lenses, which in geometrical optics, we always consider them as ideal, the problem is that they suffer from something called spherical aberration. So if we look really close up and look what's happening here, we see that the peripheral rays are being bent much more than the central rays, creating a certain mild myopic effect peripherally and an area of confusion that is not technically a small sharp point. Now, if we look closer what's happening on these photons when they hit this lens, we see that centrally there is an angle that is almost perpendicular, while at the periphery there is definitely an angle that is less, and these photons have more time to travel in air or in space before hitting the lens. And granted that the lens slowed down these photons, we know that the peripheral photons will have more time, more speed ahead of the central one before they hit this lens, which is even thinner here at the periphery. So again, what's happening here is past this lens, the peripheral photons have a lead over the central photons. This wavefront is changed already. And that's what we call spherical aberration, because any spherical lens that is typically convex, biconvex, will suffer from that. Concave will basically diverge the photons, and it's exactly the same. And that's why on many of these 20 diopters and 28 diopter lenses, it's written aspherical lenses. They're not spherical to account or to kind of cancel this effect. Now, look what happens actually here. If we have a beam of light entering the pupil, instead of having a single point, we're having a huge blur like you see here. And that's the reason why we see halos around the letter of E on the standard chart. Now, the same thing, a point spread function, instead of being a single point, we see kind of a halo around it. Now, what about if we have bright light outside? The pupil gets smaller, as you see in this case. So we have a narrower path of light going in. And as we notice, the peripheral rays of light will not have much say here. And then this halo will be much less. And that's the reason why spherical aberration is more prominent at night when we drive, and we notice them more because the pupil is larger. Now, how about coma? A way to describe coma that is also clinically relevant is its off-centered spherical aberration, or it's actually rays of light that are, or waves of light that are hitting the lens at an angle, and the lens suffers from spherical aberration. So I'm going to give a simple example of that. We have the same lens which suffer from spherical aberration, and we have the lights now hitting at an angle. So what's happening? The central waves are getting on the retina, but the peripheral waves are actually diverged differently. The top one are actually converged all the way down. The bottom one are converged much less due to the different angles of incidence they're hitting this lens on. And if we continue the same path of light, what we end up with is definitely a deformed wavefront, more so superiorly than inferiorly. And when it hits the retina, as we notice, we first have a spot of light, and then the more we go further one direction, it gets blurrier and blurrier. And that's in contradistinction to the spherical aberration, where everything is actually blurrier around the same single point of light. And that's why we see the letter of E with a smudge on one side. We see the point spread function smudge also on one side as well. How to measure these aberrations? There are a lot of aberrometers out there, and it was a major breakthrough when they first were applied on the human eye back in the early 1990s. One of the most common aberrometer is the Hartmann-Shack aberrometer. So the way it measures the aberration in a human eye is by sending a beam of light, usually an infrared laser light, all the way to the retina. The light will bounce off the fovea and bounce back. And then as it exits the eye, it will be focused with a lens array to a CCD camera. And that's the image we get. And we're very familiar with this image, but I'm going to discuss exactly how this works. So an ideal wavefront will hit those lens arrays and will get focused. And if it's ideal, it's a perfect wavefront, it wouldn't have changed. The optical path of light will be the same in and outside the eye. So it will land exactly where it started off. That's why when they look at the CCD camera, there's nothing happening. These points of laser beams, the light returns exactly at these points. Now, how about an aberrated wavefront, which usually comes with different slopes, and every lens that he will capture one slope of the wavefront, and it will be converged at a different distance from the ideal distance it emerged from. So what's happening here is that these laser beam are coming back not exactly where the grid, the intersection of the grid was. The difference between these, as you see in the white arrows, is actually the aberration on every point. Now, of course, this is how we plot the aberration. So we have the differences plotted. And if we take the derivative, X and Y derivative, we end up with a three-dimensional map. And this is the three-dimensional wavefront. Now, Zernike polynomials are a way to decompose this wavefront, because we want to decompose it into things we can understand and we can clinically relate to. Fourier is another mathematical derivative based on sinusoidal polynomials, and another derivation based on Zernike but made more clinically relevant, recently published by Damien Gattinan. It was part of his thesis. Very interesting publication and work. But at least what we still are working with now is the Zernike polynomial, which decomposes the wavefront into different shapes of increasing complexity the more we go down. Now, fortunately, most of the aberrations are in the first top 5 degree of radial degrees. So if you look at the second order aberration, they're actually called lower order, they're astigmatism and defocus, and these can be corrected with conventional ablation or with spectacles. But higher order aberration, like coma, trefoil or spherical aberration you see here, are called higher order aberration, and they cannot be corrected with spectacles. They are referred as a waste basket term as irregular astigmatism, but they actually are higher order aberrations, and they only can be treated by custom ablation. If they are present on the anterior surface of the cornea, they can be treated by an RGP lens. An interesting thing that would not be written in books, but you could notice, is that when you look at RMS wavefront, everything that looks coming down, so basically in the blue or green, are actually converging rays of light or converging wavefront of light, and they're called myopia. While anything that is red, they're actually on top, they're diverging, and they're actually hyperopic areas. So it's a little bit counterintuitive because we are used to topography and it's different. So I'm gonna give you a trick. This is the root mean square of a keratoconic patient. Again, this is temporal side, so this is where the cone comes from. The blue is myopia, and the red, because they're more in front, they're actually divergent light and they're hyperopia. But if you look at the diopteric conversion, so if we look at the conversion in diopter, which is clinically practical, we see that actually what was blue is red, so conventional to topography, and what's red is blue now in the area of hyperopia, conventional with topography. So it's an easy way sometimes to look at and try to understand our topography based on aberration. Now, how about talking about topography in keratoconus? How about very aberrated eyes? The problem with these eyes is that the slope is quite steep, and when they hit those lenslets, the lenset will converge them really far away. We will have some kind of a crossover. We really don't know if this point comes from this lenset or that lenset, and we end up with something called aliasing. And that's the problem and the limitation of many aberrometers. And this is where there are some innovative aberrometers like the pyramidal sensor, which I'm not going to discuss in detail here, but they actually use a pyramidal system which will split the rays of light into a forced subpupils. And by doing this, we have a huge, many thousands of gray, as we can say, differences between one and the other. And based on this very simple algorithm that we can check if the patient has spherical aberration, coma, or trefoil, and that can resolve up to 45,000 points on a 9mm pupil, as opposed to 1,000 plus max with Hartmann-Shack aberrometer. Most importantly, there is no aliasing, perfect for evaluating keratoconic eyes or even trifocal IOLs. As you can see here, you can see the concentric rings of these IOLs, something that could not be possible with the normal Hartmann-Shack or churning aberrometers that have very low resolving power and, more importantly, dynamic range. So few clinical application of wavefront technology, because we have to go to some clinical application. Doug Cope back in 2003 evaluated all the pre-LASIK candidates, young pre-LASIK candidates, and discovered that the total on a 6mm optical zone or pupil, total higher order aberration was 0.31 RMS, the coma was 0.17, spherical aberration was about 0.13, and trefoil was about 0.15. Now, interestingly, when you convert to diopters, these change, but the best optical zone that will be not much different between the two would be about 6mm. So 5.5 to 6mm is where the RMS will look a little bit like the diopter, a little bit more. So if we have 0.31 with the RMS, the diopter would be like 0.28. So this is the closest possible. Again, when you refract somebody, whenever you have a sphere, it's made of defocus, but of also some higher order aberration, a spherical aberration, 4th degree and 6th degree. Cylinder would be astigmatism, but also coma, also secondary astigmatism. So we have to make sure that when we refract, we have to understand that some of our refraction, it includes some higher order aberration. Now, how about as we age? We know that our lens, our cornea, has positive spherical aberration because it's a convex cornea, as much as the cornea is aspherical. But what happens here, our lens negates some of this spherical aberration. We have negative spherical aberration in the human lens. Now, you might tell me, well, one second, you're saying negative spherical aberration of the lens. Isn't the lens kind of biconvex? How can it have negative spherical aberration? It should have positive spherical aberration. Well, let alone the fact that the lens has steep posterior curvature, steeper than the anterior. What the lens has is actually a gradient of index of refraction. It's not a normal optical system. The center is high in index of refraction, the periphery is low, and that will offset the fact that in a biconvex lens, the periphery will converge more. Actually, because of the lower index of refraction, it will converge less. But as we age, what's happening is changing of the lens, not necessarily cataract, but going towards the cataract, the lens picks up more high index of refraction in the periphery, almost getting very close to the center, and then we end up having positive spherical aberration of the lens. And this is where the total would start increasing much more than the 0.13. And what happens when we go ahead and exchange that lens with a traditional biconvex lens? The traditional biconvex lens has a lot of positive spherical aberration because the index of refraction is the same. So we end up with about 0.27 here, 0.20 there. We end up with about 0.46 RMS with spherical aberration. And that's why we have aspheric lenses. Aspheric lenses have either a prolate, meaning centrally steep anterior surface, like the Tecnis lens, or creating negative spherical aberration of about minus 0.27, or we have posterior oblate, so meaning the center is flat, posterior surface, which also create negative spherical aberration, like the Alcon lenses, and that's create about 0.19 RMS. But also pay attention that this is important when the pupil is big. With smaller pupils, less than 4, we know that the aging population will lose about 1 millimeter per decade. That's going to be less and less important. How about myopic treatment? We know that when we produce myopic treatment, the central rays of light will take more tissue than the periphery. On top of that, we have the loss of fluence because of the angle the rays of light are hitting the periphery. So we end up with a very oblate-shaped cornea, and that makes the center much flatter than the periphery, which means the periphery is steeper. It will focus light much more than the center, and that's a recipe for spherical aberration, which increases dramatically after myopic laser correction. And the treatment for it, or the best way to avoid it, is actually to use 1, large optical zone, and 2, compensate for the radial loss of fluence, which now all the lasers actually do. Hyperopic laser vision correction will do exactly the opposite. It will steepen the center, flatten the periphery, creating rays of light that will bend less at the periphery than the center, and that's by definition what we call negative spherical aberration. So negative spherical aberration is when then the periphery is bent much less than the center. If it's bent more, it's positive. The very few slides here, I'm just going to show common diseases and their aberration. Keratoconus, look at that cone in here. So if you look at the total aberration, remember what I said with the RMS, it's counterintuitive, but it's in blue because it's minus, because those rays of light are converging. But look at the dioptric way, and I'm isolating here all the aberration except the coma. You could see that this is the coma, where the coma is, and if you convert to diopters, so basically you end up with almost the same color. So you could tell that this is where the coma is. Another example would be decentered ablation. That's a patient post-myopic laser with decentered ablation. Again, remember what I said before, a decentered spherical aberration is coma, but here we're creating spherical aberration and it's decentered, so it's typical for coma. Again, this is the diopteric way and this is coma. It's actually 1.82 coma, that's a lot. And finally, radial keratotomy. As we see with topography, we have severe flattening with an inflection point. Those are instantaneous curvature mapping. Definitely we have positive spherical aberration, but what's typical in all the RK patients are actually the trifold and the quadrifold or tetrafold. Whenever you see these 2 plus spherical aberration, think of RK as well. Thank you.
Dr. Shady, thank you so much for that fantastic lecture. So we're going to move on to Dr. Karolinne Rocha with Show Me the Math. Now her questions, I do recommend that we take out our pencils and pens and paper. When have we done that last? We're always relying on calculators, but it's a lot more fun, believe me, if you actually try and do it. You know, I was just watching Genius Junior, and it forces you to think in your head, and it's a lot more fun to do so. Dr. Rocha has a very, very impressive CV. And following optics and aberration, she's the perfect one. She's Associate Professor of Ophthalmology, Director of Cornea and Refractive Surgery, Fellowship Director at the Medical University of South Carolina, Storm Eye Institute. She did her ophthalmology residency at the Cleveland Clinic Foundation Cole Eye Institute and her PhD in optical aberrations in pseudophakia and cataract at the Federal University of São Paulo in Brazil. She's the associate editor of the Journal of Refractive Surgery. She's on the Refractive Surgery editorial board for the Ophthalmic News and Education Network by the AAO. and she's the associate editor of the Brazilian Archives of Ophthalmology. She's also won numerous awards, including the American Academy of Ophthalmology Senior Achievement Award. So Dr. Rocha, thank you so much for being with us today.
Thank you so much. This has been wonderful. And for our residents, we know they are taking the OCAPs soon, right? So I hope they are ready to go with a lot of questions here. All right, you ready? Show me the math. So we'll great presentations today. All right, so we have a few questions here and some cases. Again, this is a wonderful panel. Thank you very much for the invitation. This is fun. No financial interest related to this presentation. Okay, so this is a case here, right? So if you can write down the numbers. So it's someone that comes in with minus 7.5 diopters of myopia, central pachymetry 525. This patient has a pupil size of 5.5, diameters under low light conditions. And just again, right now the numbers, our flap here, 160 microns. This is again, just for calculations. We know our flaps now are much thinner, with especially with femtosecond lasers, right? Usually around 100, 110. The ablation depth is 90 microns. And my question mark there is, what is the residual stromal bed? Let's see, anyone can help us with that?
We have Dr. Precious Fatudi, a refractive surgeon ophthalmologist from South Africa. Dr. Precious, will you give us the best guess on this question?
I can go back. CCT 525, flap 160, ablation 90 microns. Ablation zone is larger than the dilated pupil. So the ablation zone here is 6.
Dr. Precious, are you with us?
3, 6. I am.
Okay, perfect, perfect. Take your time. It's not, you know, we're putting everyone on the spot with these questions.
All right. Just to correct you, I'm not a refractive surgeon. I'm just a normal ophthalmologist.
Well, thank you for being with us.
Can I just have I choose D.
All right, so let's see here.
317?
Yes, actually the residual stromal bed will be 275. And let me show you why here, right? So how do we calculate the residual stromal bed? So it's our central corneal thickness, CCT, minus the flap, minus the ablation depth. That's what's gonna give us that residual stromal bed. That is still important, you know, it's still an important number. We're gonna discuss a little bit why, right? So we look at our residual stromal bed. It's just one of the parameters. And then again, this is actually the very first one of the publications, you know, including some parameters. We know now that we like to include especially information on corneal biomechanics, right? We know some of the devices are still under investigation here in the US, but they are approved overseas. I think, again, this is even, you know, we mentioned we don't actually follow all the criteria here. There's a lot of publications, even Bill published some studies here. But again, definitely, you know, having a very low residual stromal bed is high risk, right? In terms, it can affect that random score. That again, at that time, they included topography, placido topography, the residual stromal bed, age, the corneal thickness, and the amount of refractive correction, right? Of course, these days we want to look at corneal tomography, corneal biomechanics, and some of the other parameters here. This is just, again, the basics of, you know, the amount of ablation or the ablation depth, right? I would say according to the OZ, the optical zone here. It's just an example. For example, if you're using a 7 millimeters, if you're treating 1 diopters around minus 16.3, but it really depends on the ablation profile, right? If you're doing a wavefront guided treatment, I remember, when we did the trial for wavefront guided, one diopter, you can maybe ablating up to 20 microns, right? So in topo guided ablation, especially in highly aberrated eyes, again, to treat one diopter, you may be ablating and removing more tissue. Question number 2, this is important, again, for the residents, for OCAPs and the ones taking tests, right?
So before we do it, I want to make sure this person focuses. A very smart person that we have in the audience, Dr. Nandini Venkataswaran. Nandini, are you there?
Yeah, I'm here.
Yeah, Nandini is currently at Duke for cornea and refractive surgery fellowship, and she's going on to Mass Eye and Ear for faculty. And she's at my cornea fellowship. So Nandini, this is your question.
All right, Dr. Trattler earlier today, he mentioned the PTA, right? So let's see, who knows? PTA, all right. Okay, again, same numbers. We're treating -7.5. This is our correction here. Pachymetry 525. Our flap is pretty thick flap, 160 microns. Ablation depth is 90. And the residual stromal bed, now we know, is 275. And that is our ablation zone. But here again, we're telling you that we're treating 90 microns. This laser, 90 microns to fix -7.5. All right, ready? Tell me, what do you think? What's the right answer? What is the PTA in this case?
I think it's B, 47.6.
All right, yay, good job. Good job. All right, so let's talk about the PTA. So this is actually one of our friends in Brazil, Marconi. He did some studies. Some people may follow the PTA, and we're going to comment on the formula, but usually if it's higher than 40%, there's a higher chance that in terms of risk of ectasia. But again, I think these days, what we do, we want to make sure we add biomechanics into account when we are selecting these patients and calculating or trying to assess the risk of ectasia. Bill also mentioned epithelial remodeling. We did a lot of studies on epithelial remodeling, can really help us, especially differentiating warpage versus someone with ectasia. Remember, in patients with corneal ectasia, the epithelium, we see actually thinning of the epithelium over the cone, right? So if you're seeing thinning of the epithelium, this is definitely a red flag, right? In warpage, we see a thick epithelium. Again, a lot of devices and technologies that can help us, right? So, but again, for your test, PTA equals flap thickness plus ablation depth divided by CCT. Good to go?
Excellent, excellent.
All right, let's get going here. So
for the next question, I'm gonna have ready if Dr. Kirsten Wagner, are you with us?
Yes, I'm here.
Dr. Kirsten Wagner is a cornea fellow at Wake Forest, am I correct?
Yes.
Okay, the next question is for you, Kirsten.
Okay,
thank you.
I'm gonna tell Keith. I'm gonna call Keith. Good. Okay, so this is a hard one because you need to remember the formula. 45-year-old female, refractive error in the right eye is -5, left eye -3.5 sphere, right? And the patient decided to proceed with LASIK, mild myopia. Very small optical zone. This is not the usual, but just for the calculations, 4 millimeters. So what is the ablation depth in microns? And they're saying, oof, that was going to take a little while to calculate.
I try to do it without a calculator, Kirsten. We'll be here for a while.
And I'll tell you, let's just tell you if you remember the formula or the name of the formula, right? We can take that.
Yeah, so we could talk through Munnerlin's formula.
Yes.
Which is the
optical zone squared. So 4 times 4. And then for the right eye, times 5, sphere divided by 3. So it would be 26.67 for the right eye. So I think that would make it C by default.
Yay! Oh my gosh, you're
Impressive.
fast. Great. Again, this is important for the residents, right? And everywhere. Just to have an idea, it's just for the boards here. But again, the depth of treatment zone equals square of optical zone diameter times the refractive error divided by 3. And we're calculating for the right eye that it was -5, and for the left eye. Great job. Very good.
Excellent.
All right, let's keep going here. Question 4, and again, I've seen questions here before. This is a patient that comes in for cataract surgery. Axial length in the right eye was 27.17. Do you want to ask someone about this?
Yes,
This is a hard
yes. So we're going to ask Dr. Ankita Thali. Ankita, are you there on the line? If not Ankita, then we have with us Mei Zoon Angwin from Myanmar. Are you on the line? And then Piyusha Vagmare. If you're on the line and can hear us, can you chime in just so we know before we start the question?
Hello, yes, ma'am. Yes, hello.
Hi, Piyusha.
Hi, ma'am. I'm on the line.
Piyusha is my KEM resident. So, Piyusha, it's a tough one. Okay, so brace yourself.
And again, you don't need to calculate. You just tell us your thoughts. Okay, that's fine.
Okay,
Just
ma'am.
tell us. So, Young Koch adjusted formula. You know, what Young formula would you use to calculate the axial length for this patient's left eye? Okay, so it's a little tricky. The axial length in the right eye is 27.17 millimeters, left eye 26.47. So we know this is a high myopia. You know, if you look at the IOL, there's 10, 12, 11. Numbers are all over the place. And you don't need to calculate. Maybe just tell us your thoughts.
Do you want to show her the options, Dr. Rocha? Because it's a tough one.
It's a tough one.
So Piyusha,
yes,
this will be next week's lecture for you. Don't worry. But in the meantime, give us a guess.
No, ma'am, I'm not able to guess. Just never seen.
Anyone, A, B, C, D. You've got four choices.
Okay, for C.
Uh-oh. Okay, good. Hey, this is a hard one. So let's talk about that a little bit. So just to understand, right? Optical biometry assigns the same refractive index to all eyes. So what happens in a patient with a really high axial myopia? The greater the vitreous cavity in high axial myopes, the more its index of refraction contributes to the measurements. That's why, you know, Young Koch, they suggested this adjustment, especially if you're using third generation formulas. We're going to talk about that, right? So it's just for Holiday 1, SRKT, you know, mostly Holiday 1 is when they publish all the data, third generation formulas. But we know that optical biometry overestimate the axial length. So that's why this adjustment. So, but if it's a patient's, you know, I would say up to 27, we'll just need to change here the numbers. You know, for axial length greater than 27 is 0.8814 times the axial length plus 2.87. And for eyes, I would say greater than 25, it's 0.8289 times axial length plus 42,663. Big numbers, but they like to ask this question. So now you all know. You can take a picture of the screen now And then you'll be a very smart resident fellow when you're attending. I don't know if my fellow is here, but he is in trouble tomorrow that we have to. All right, good, good, good. Okay. So I just want to share this study here. It was published by Jack Holliday Group. And this is really interesting. You know, it's like 15,000 eyes. And then he compared all formulas in all the different axial lengths. Is it in normal ones? As we can see here, all formulas, they work really well, right? And this paper is really important because it taught us, you know, I think when I was a resident, I remember, I think someone needs to mute.
Kindly, if you can, if you have your microphone on and are not Dr. Rocha, kindly, if you can mute yourself, we'd appreciate it. Thank you so much. Sorry about that, Dr. Rocha.
No problem. So, but you know, remember when I was a resident, we used to say that SRKT was the best formula for long eyes, right? But if you look here in eyes with axial length greater than 25, look what happens with our SRKT, right? So again, we've learned from this study that for long eyes, Barrett, that is the red, right? And Olsen, where's Olsen? The purple. Those are the two best formulas. And look at short eyes. Remember, again, we learned that Hofer Q was the best option. And look at our Hofer Q here, right? So this paper I really recommend. It is really interesting. This is just based on axial length, but it looked at ACD, corneal power, for example, eyes with really steep case, you know, SRKT does poorly. And then when you look at your patients now, you know, you will see why the formulas, the numbers are all over the place, right? But again, for short eyes, I would say Barrett did it really well. Even the Holiday one, right? But again, we're talking about to keep the young coat correction, actually showing that, you know, actually even Barrett and Olsen did even better than the optimization, the Holiday one, young coat optimization, and the Hofer Q optimization. So this, again, I remember this slide from the ASCRS. Just remember the formulas are all different, right? So the versions formulas here, the third generation formulas, Holiday 1, Hofer Q, SRKT. And ray tracing formula is Olsen's formula that requires ACD lens thickness by optical biometry. Is again a great formula for long eyes. Barrett Universal 2, it's a versions formula, and now we know if you have an IOL Master 700 that you can use the Barrett Universal 2 TK using the total cornea power. It's even better than the very first Barrett Universal 2. And I truly believe that artificial intelligence is the future. It's not a real formula, it's just an algorithm, because we're just collecting and getting all this data and this new information.
It's very unique and it's very special. And so it actually has a very deep place in my heart. It's called inner sight relaxation. And, you know, we're told that the eye is the window of the soul, but no matter how many ways we slice it and dice it, and believe me, as a corneal surgeon, I've sliced and diced it up in many ways, right? But no matter how many ways we slice it and dice it, do we see any deeper than the eye? Who in this platform has actually seen into the soul? And so, well, my best friend, revered Dada J.P. Vaswani, he was titled as Saint of the Century, is the epitome of love, compassion, humility, and simplicity. And this inner relaxation hopes to bring out something beyond what we learn in ophthalmology residency training. It's about life and it's about universal love. And so this is a time for us to just close our eyes. Whether or not we've meditated in the past, it doesn't matter. But just close your eyes and take time for yourself. That's the message. So here we go. Enjoy.
Meditation is the key to living a more rewarding, fulfilling, peaceful life. It helps you discover who you really are and what your true potential is. It enhances your ability to face life and its challenges. Meditation is not strenuous or difficult. It is simple and life-changing. The positive energy and healing vibrations of group meditations are tremendous. The force of group meditations has a great impact on every member of the group. Meditation begins with relaxation. Most of our time we are tense without realizing it. We need to relax consciously, allowing the stressed out and exhausted mind to rest. There are many ways of relaxation. Each one of us must follow the one that best suits him or her. I will but indicate to you today one simple method. Sit in a comfortable posture with the back straight as far as possible. Let the back, the neck, and the head be in a straight line. Close your eyes and take a deep breath and exhale. Do this a few times. Let your face wear a smile. Now sit still and breathe normally. Imagine yourself in the loving, the immediate, and the personal presence of the Lord, your beloved. You are sitting at his lotus feet, your arms around his ankles, your head resting on his feet. Say to yourself, here is true rest. Here is true relaxation. Now relax the body, every muscle of the body. To relax a muscle, you must first tighten it and then release it. Remember that all the while you are in the loving, immediate, personal presence of God. We will now move from one limb to another by tightening it and then releasing it. Let us begin. Bring your attention to your feet. Tighten and relax. Legs. Tighten and relax. Buttocks. Squeeze tight and let go. Abdomen. Tuck it in and relax. Chest. Expand and relax. Shoulders. Lift them upwards and drop them down. Raise your arms and drop them. Turn your attention to your neck. Gently turn it from one side to another. Arms stretch tight and relax. Hands tighten into fists and relax. Relax, relax, relax. Let go, and let God. Now tighten your whole body and relax. Repeat this 3 times. Take a deep breath. Allow your stomach to expand. As you breathe in, hold the breath for a few seconds and then breathe out through your mouth, allowing your body to completely relax. Now rub the palms of your hands together and gently, very gently, place them on your eyes and open them. Continue to smile. Thank yourself for this beautiful gift of a few precious minutes of peace. Slowly turn your gaze around and become aware of your surroundings. This is the end of the meditation. Om Shanti, Shanti, Shanti.
Thank you everyone so much for being a part of that meditation. My name is
Thank you, Pragriti, for playing that so much. So a special shout out to Pragriti for being here. She's from Cornell doing her master's in health administration and has interned with me and has been doing the behind the scenes work for this. So thank you so much, Pragriti. We are on. I hope you have all enjoyed that. You know, taking time for yourself in whatever way, whatever sport, whatever activity that you do, taking time for ourselves is really important. And doing this group meditation, especially in the time of COVID, when so many of our loved ones are suffering in this world, I think we can send out our positive vibrations to them. So next up we have Dr. George Waring IV. Dr. George Waring IV is the founder and medical director of the Waring Vision Institute in Mount Pleasant, South Carolina. He has served as adjunct assistant professor of bioengineering at the College of Engineering and Science at Clemson University, as well as associate professor of ophthalmology and director of refractive surgery at the Medical University of South Carolina Storm Eye Institute. He is a diplomat of the American Board of Ophthalmology and a fellow of the American College of Surgeons. Dr. Waring has received numerous awards and distinctions in ophthalmology, including the Presidential Award and the Distinguished Lands Award, both from the International Society of Refractive Surgery. He is active in clinical research and incorporates the latest advances in technology into his practice. He has performed surgery, taught new surgical procedures, and delivered invited lectures on 4 continents. Thank you so much, Dr. Waring, for being with us today. It's such an honor to have you. And so without further ado, we have Change It Up, Range It Up, lenticular refractive surgery.
Thank you, Ash. And thank you all for being with us today. That's a tough act to follow. And I am feeling extraordinarily relaxed here in space.
We love your background. We love it. I think you win for best background.
Well, I think our last lecture won for best lecture. That was extraordinary, so thank you. So we're going to be coming somewhere in between a meditative state and out of a meditative state and learn about lens-based refractive surgery. And these are my financial disclosures. And I'm going to start with a kind of a decision-making tree that that is a adaptation from the Cornea Bible, the Kratchmer textbook. This is a chapter that that we have written for a number of years on decision-making in refractive surgery. It was co-authored with my late father, and we adapted this and actually use this in our practice every day. Just in terms of giving our team members essentially a standard operating procedure based on how patients present by age, by their refractive error, and then when we have more information with lens opacity and what their topography looks like, we can assign a stage to their aging and then help ourselves determine what track they might be on, whether it's laser vision correction or implantable contact lens, refractive lens exchange, or cataract. And what we're going to do is we're going to start with implantable contact lens discussion. And this is a technology that's been available in the US for well over a decade, is indicated for use in adults between the ages of 21 to 45 years of age for on-label use, and we do use this off-label. And the indication for treatment of myopia in the United States is for the correction of myopia of -3 diopters to -15, but it's also on label for the reduction of myopia for -15 to -20. And you just have to think about that's an important use of this technology, because many of these people that are extreme myopes don't have the opportunity for vision correction otherwise due to the risk of retinal detachment with lens replacement and removal of too much tissue with excimer vision correction or with SMILE. The toric ICL was approved about 1.5 years ago in the US for the treatment of astigmatism, myopic astigmatism, the corneal plane of 1 to 4 diopters. And you need to have an anterior chamber depth of greater than 3 millimeters. And when you measure that, that's from the endothelium to the anterior capsule of the lens. And this is something that allows you to access your online calculator when you determine what your length you're going to use, because this comes in different sizes. And so not only are you determining your spherical equivalent power for your implant, which is based off your refraction, not your axial length, you're also determining your toricity if this is a toric ICL, but you also have to determine your size. And this is kind of the art of implantable contact lenses, is using what in the FDA studies was based off of the white-to-white measurements. And there are a number of ways that you can calculate your white-to-white to determine the length of the ICL. So we do not have access to the EVO lens in the United States with the Centraflow, as you see below. And for those of you in the free world, many of you are in the free world on this webinar, you do have access to the Centraflow. But here in the United States, we still have to do peripheral iridotomies. We try to do this 1 to 2 weeks prior. And the recommendation is for 2 of them at 10 o'clock and 2 o'clock. And the idea is that you want to at least have one that's patent, and that's why it's recommended to have 2. And for a thick or a dark iris, you can combine the argon laser, like we all learned in residency, to make these treatments much, much easier, often with a single shot prior to your peripheral iridotomy. Now, this is a very useful video from the Chief Medical Officer, Dr. Scott Barnes, prepared 4-star. It just shows a couple tips. Half the procedure for implantable contact lenses is actually just learning how to load the lens. So one of the tricks is that you can wet the Vukich forceps, and this helps demagnetize the forceps. That reduces the stick to the polymer material. Another nice trick is to do a very gentle flush of some of the ocucoat from the lumen, and that allows for a little bit of a quicker unfolding as it exits the lumen. Now, here's an example from a case of mine a number of years ago with a decent amount of with-the-rule astigmatism in a young high myope with thin corneas. And at the time, we did not have toric ICLs. So what I did was I made a superior on-axis incision of 3.2 millimeters and coupled it with a 45-degree inferior incision that you can see that there's some bleeding from all the panas from a lifetime of contact lens use. And then we simply just tuck in the haptics, trying to stay away from the optical zone as you cross over the ICL. Here's an example of what this patient looked like immediately after surgery. And what we're evaluating essentially is the vault. So let's talk about vault here. Vault can be measured under the slit lamp, can be measured with OCT, as you see here. And here this vault measured 674 microns in the patient we looked at. We also take a second look at the angles as well to pay attention. It gives you some information on how the lens is sitting in the ciliary sulcus. And this is, and in terms of your post-op care, this is just routine, just essentially like your cataract patients, may not need the non-steroidal. And also just like your LASIK patients, you're doing essentially the same type of post-operative evaluation. However, if we could have everybody mute on their phones and computers, please. But you want to make sure we're checking the fault. And also, of course, you're checking for pigment and inflammation and pressure is important as well as the patency of your iridotomies. And the most common complications here are typically insufficient iridectomies leading to an increased pressure with a pupillary block. And this can occur because you can still transilluminate and still have not total patency. So you want to resist the urge to go too small or too peripheral, which is a human instinct when we first start doing these. And you want to be a little more liberal in your size and not in the far periphery when we do this. And that can really improve. Now, I am going to ask a question of the audience. And so, Ash, if you want to tee this up, here's an example of a high vault. But what the question is for one of the residents or fellows, where is the vault here? And this is a little tricky and subtle when you first start looking at ICLs. So we're giving you a hint with the graphic. but you get a choice. Is A the vault on the slit lamp? Is B the vault? Or is C the vault? And Ash, you want to call in somebody?
Yeah, I mean, so I don't know if it's a resident or a specialist, senior specialist, so forgive me, but we have Jenny Jetnani on the line. As well, we have Dr. Lakshmi Katana, who I know is a fantastic corneal surgeon. So if either one of you can give us your answer. Okay. Then we have with us Dr. Berg. Dr. Berg is a senior refractive surgeon. Dr. Berg, will you chime in on this one?
Yeah, I would think it's B. If you look, that's what I think the answer is B. But I've done a lot of ICLs for the last, I started 20 years ago, and I think it's a great technique, but I would say the vault is B, in my opinion.
Yeah, this is a tricky slide, and thank you so much. The vault here is actually C, but it's almost not a fair question because of the small image, and this is a lot different if you're looking at this in high mag and in a full view. And so the vault here, you want to have about a corneal thickness, usually around 500 microns. So you can see here, this is about 2 to 2.25 that, close to probably over 1,000 microns. And that's where we start to potentially run into issues with angle, closing off the angle and angle closure. If we have the opposite in a low vault situation, you can see that little thin slit that's about half of a corneal thickness on the right. Then it sits too close to the crystalline lens and we start to get early anterior subcapsular cataracts. So just when we look at this, one of the neat things about implantable contact lenses, and you just heard from Dr. Berg about why this is such an important technology, is that we can often improve best corrected acuity. And you can see that in Dr. Parkhurst's review early in 2011, that over 1/5 of patients gain one line and 13% of patients gain 2 lines of best corrected acuity or uncorrected acuity compared to their preoperative best corrected state. More recently, they looked at what's called supervision acuity in the military and found that you actually get a higher percentage of supervision acuity in implantable contact lenses and supervision contrast, and for things like night driving and just extraordinarily high contrast image in ICLs compared to LASIK. So what I want to do here is shift gears now to our to another lens for what happens when this stops working. This is kind of a neat video from Butch Harden that shows that with a UBM, actual real accommodation and the increasing anterior posterior lens thickness in the accommodative state for increased refractive power. And a number of years ago, our friend Daniel Goldberg published his work on probably the most robust description of accommodation mechanisms known to date. And this was featured on the cover of the Journal of Cataract and Refractive Surgery. How many of you knew that there was a ligament on the human crystalline lens? Weigert's ligament. How many of you knew that there were actually zonules that attached to the vitreous body, vitreous zonules? So this is far more complex than we ever considered or ever thought. And it's really important as we look at advances in presbyopia correction. And when we think about the opportunity here, this is an important year for refractive surgery. 2020, there are over 4.2 billion presbyopic eyes worldwide. And that has a massive impact on not only on quality of life, but even being able to perform daily activities and even work. And this is becoming its own entire subspecialty. I mean, there are so many ways. If you think about glaucoma subspecialists, now we have the potential for presbyopia fellowships for the correction of presbyopia because there's so many things that we can do. And the age-old question is, well, of the lenses that we have available to work on, which one do we work on? The cornea, which has always been more accepted and less invasive. We do this in our laser suites. But shouldn't we be considering going to the source of the problem because it addresses the source of the problem? And it's a permanent solution, can often be therapeutic, as we'll show you. So a number of years ago, with Dan Dury and Jason Stahl and myself, we proposed a terminology to the scientific community called the dysfunctional lens syndrome. This is just merely an attempt to scientifically characterize the aging changes of the human crystalline lens. And we went on a step further and proposed stages to this. The first stage is just presbyopia. The second stage is early opacities. And the third stage is a cataract, where those opacities become manifest to the point that patients can't perform their daily activities. And this has now been accepted by the American Academy of Ophthalmology, actually, as a known clinical entity, which is kind of neat. So we're all starting to speak the same language, and this really kind of helps. And when we're talking about these things to our patients as well, we have advanced diagnostics now based on some of these terms. The eye tracing, which is a ray tracing aberrometer, actually has a dysfunctional lens index to help separate out internal aberrations from external aberrations. And they also have an opacity map as well that allow us to look objectively at some of these aging changes. And then, of course, we have good old-fashioned slit lamps and double pass wave fronts that show us image quality on the retina too, so we can actually see how patients' vision's performing. This is my eye, and luckily I see well for distance. I do not see well for reading anymore, and I now need reading glasses. And it is something that is, it's like being a presbyopia anonymous. It's really something when it happens to you. You like, if you're a plano presbyope, we like to think that we're falling off a vision cliff. No kidding, when it happens. Here's our first stage, where that is exactly what happens. But we still have a clear lens, so we may think about doing a lens-based procedure. Here's an example of this. In the internal optics, the dysfunctional lens index is still very good, but in this post-myopic LASIK patient who wants correction, we got to think about what's the right thing to do, because this is all external aberrations. Second stage, now we're moving into some internal aberrations. We can actually see this and measure it objectively, where this, if we do a corneal-based procedure, it's not going to fix part of the problem here, put them in focus, but you still have aberrated internal optics, as you can see here with the eye trace, and the dysfunctional lens index is poor. So now we're thinking about a lens-based procedure. And then our third stage, now it's so poor that this is kind of a no-brainer. If you did LASIK on this patient, that's a real problem. They are not going to see well. This is a cataract. This patient cannot drive at night, and in the United States qualifies for reimbursement through insurance or Medicare. And so here's just a mock-up of the different stages through life of the aging lens and how we can look at these things objectively to help us better understand where we should be addressing these issues, the cornea or the internal lens. So here's an algorithm that we've proposed for stage 2 and stage 3. Essentially, this means lens-based procedures in the, as far as what's approved by the FDA. This is a schematic of a dysfunctional lens replacement or laser lens replacement that this really resonates well with patients, because we have now lasers that we can do this. This is our preferred technique, which is a femto chop. That's what we call this technique, and makes this very easy for soft lenses. As you can see here, as we all know, chop techniques can be tricky in soft lenses. And but now that we have lasers to do this, this actually makes these procedures much more straightforward. And the patients really appreciate the fact that we're still using lasers, and we're just using it on a different lens. Instead of the cornea, we're using it on the internal lens. And you can see again, we also can tell them in good faith that this takes the same amount of time as LASIK. They really don't feel anything like LASIK, but it has a couple real benefits to LASIK in that it prevents cataracts. It's permanent, instead of doing LASIK now and lens procedure in 5 or 10 years. And more importantly, and we're formally studying this, it maintains stereo acuity. And we all know that with summation, we have better distance and reading vision. And we just tell them it's a lot easier seeing with 2 eyes instead of 1, just like it is lifting something heavy with 2 hands instead of 1. And everybody understands that, and everybody appreciates that. So we've studied this formally and prospectively in pilot studies, and have since gone on to publish a lot of this work. But we can do something that LASIK can't do. This is improving image quality because we improve the early opacities in the lens. So what does this look like? We essentially double their image quality. So yes, we're getting them out of glasses, we're fixing their refractive error, we're also fixing their reading vision, but we're doing something LASIK can't do, we're improving the image quality. And we've measured this and looked at this and compared this to LASIK control patients, and we're actually improving densitometry above and beyond what LASIK patients have because those lenses are not clear. And again, this has all been published and we've shown this to be statistically significant. Well, what about therapeutic use? A lot of these hyperopic patients have short eyes with narrow angles and actually have chronic angle closure glaucoma. Here's an example. Well, at the same time, we can actually fix their chronic narrow angles in a way that really makes sense. This patient came for LASIK. We recommended laser lens replacement, and we doubled their angle, half their pressure, and they're out of glasses. And we've presented this data over the years to show that with laser lens replacement, that we can increase the anterior chamber depth significantly. And then we've heard about the importance of posterior understanding posterior corneal curvature when we treat astigmatism for refractive lens exchange. And just to kind of cut to the chase, we have to think about these astigmats differently between against the rule, with a rule, and oblique. These are different animals, different, they're different refractive states. Astigmatism is more than just astigmatism. The posterior cornea is vertical and acts like a minus lens, and this results in against the rule ocular astigmatism for most eyes. This varies. It's much more consistent with anterior with rule patients, much less consistent in against the rule and oblique eyes. And if we do not pay attention to this, we will overcorrect half a diopter with the rule patients and undercorrect a third of the diopter of against the rule patients. And Dr. Rocha gave an excellent summary on the total cornea power now that we have available to us with advanced biometers that can measure posterior cornea with OCT. And now with the new Barrett TrueK formulas, we can actually plug this in directly. And this is shown to give essentially the very best absolute prediction error when we plug in the true cornea from the posterior direct measurement from OCT and plug that into formulae that are geared specifically for those lenses. And I'm going to leave you with one case for what happens when we don't do that sufficiently. Here's a refractive lens patient that was co-managed. Here's the pre-op astigmatism for both eyes, left, right, about 0.8 diopters tomographically. On the left of against the rule, on the left about 0.4 diopters. So we did a toric on the right eye based on posterior corneal measurements and had a great result. This was with the Symphony, so not superb reading, but about what we expect with great distance. And then we did a personalized vision approach in the left eye with a paired LRIs. Based on our nomogram, is about 35 degrees paired, but was left with a lot of against the rule astigmatism, basically the same amount. And so the patient, although they were seeing great for distance, let's look at the topography. The post-op topography was 0.1 diopters. So our LRI perfectly, but we were undertreated. So he was sent back because he could not see. So we did not efficiently treat. We didn't enhance it, and he ended up doing great. So here's kind of the pearl that we use in our clinic if you do not have posterior corneal measurements available. Generally speaking, if it's against the rule, over 0.7 diopters, we're using a toric. Okay, if it's less than 0.7 diopters, we're doing LRIs. And that's kind of the easy way to remember it. So you're almost treating twice as aggressively with against the rule all the way down to 0.7 diopters with a toric lens. So the last slide on the future, I'm going to sum up here. We're going to be treating lenses directly with femtosecond lasers. This is a project we're working on called Perfect Lens that is called refractive index shape changing. So instead of doing these enhancements, we're going to be doing this all on the lens directly in the clinic. adding multifocality to monofocals, reversing multifocality from multifocals, and that's going to give us a lot of flexibility. So in summary, think about the dysfunctional lens syndrome. It will help you in your decision making, in your staging, and also in educating your patients. And at the end of the day, modern day refractive surgery, we are not LASIK patients, we are lens patients, and there are two lenses in the eye, and it's a wonderful idea to be facile with all of them. Thank you so much for the opportunity to present to you, and everybody stay safe.
Thank you so much, George, for that. I really appreciate it. We all do. So we're going to go ahead. In the interest of time, we have 3 fantastic speakers. So we're going to do 7-minute slots for each of them, okay? So forgive me, but we want to stay on time so that everyone, you know, as best as possible. So we have with us next Dr. Audrey Rostov. Okay, a dear friend of mine. Dr. Rostov is the recipient of the 2019 Diane Sabin Mission Impact Award, and very well deserved. The 2019 Cedars Aspen's Founders Award, named in the top 100 power list for the ophthalmologist publication in 2020. She was the recipient of the Spencer Thornton 2017 Humanitarian Award and Senior Achievement Award from the AAO, amongst many, many, many more. She was the very first surgeon to perform and teach femtosecond laser keratoplasty in New Delhi, India. And she'll be able to tell you better than I how many times she's been in India, a globetrotter that she is. She's just so positive and so loving and so warm to all. And she's taught me a lot. Beyond ophthalmology, she's a dear, dear friend and a dear mentor. So Dr. Rostov, thank you so much for taking the time and being with us today. She's going to give us multiple choice questions on flap, zap, or smile.
Great. Thank you so much, Ashiyana. And it's really a pleasure to be here with so many amazing speakers. And as you could see on my first slide here, there's a beautiful picture with the great Dr. Ashiyana that we took together when we were at a meeting in Hyderabad. So welcome, everybody. All right, let's see here. So we'll go ahead and get started with the first question. And here it is. Which of the following factors has the greatest association with the development of ectasia following laser vision correction? The choices are A, age less than 21 years, B, corneal pachymetry less than 500 microns, C, preoperative myopia greater than 8 diopters, D, abnormal preoperative topography or tomography, and E, a residual stromal bed of less than 275 microns.
So we're going to give this question to Eve, and after Eve, can we please have Margaret Hubble and Neha Vyas, Joshi, Lakshmi Katana all ready to go, and Amy Verne are also. So Eve, what's the best guess you can give on this question?
Based on the Randleman criteria, I'd say it has to be D, abnormal preoperative topography or tomography.
That's correct. And so the answer is, in fact, abnormal topography or tomography. Although all of those can be risk factors with the development of ectasia, and there is no single risk factor that predicts the development of post-refractive ectasia with laser vision correction, the most common, no matter what you look at, is abnormal topography and tomography. So let's take a deeper dive here. And can somebody tell me what the diagnosis would be here?
Okay, so do we have Neha Vyas Joshi on the line? Or Margaret Hubble?
Yeah, it looks like it could be pellucid marginum.
Okay, great, yes. And why do you say that?
Because of the back elevation, particularly in the bottom right. And I can't quite see the top labeling for the top right corner, but I'm guessing is it thinning?
Yeah, so this is, in fact, this is a patient who has keratoconus, and as we could see, there is inferior steepening as well as some corneal thinning. And so if you saw this preoperatively on someone who presented to you for laser vision correction, this is somebody that you would not want to do laser vision correction on. But remember, it's really important to keep in mind that all keratoconus has abnormal topography and tomography, but not all abnormal topography and tomography is keratoconus. So let's move on here to question 2. If you do have abnormal topography and tomography, further imaging may include which of the following? A, a Bell-Ambrosio display on pentacount, B, OCT of the cornea, C, epithelial mapping, or D, all of the above.
Okay, so we have with us, we have Lakshmi Katana, if you're there, Sabrina Mukhtar, and Robbie House. Will any of you give your best answer on this question?
This is Sabrina. I would go with D, all of the above.
Excellent, D, all of the above. Fantastic. And in terms of what to look for, what we want to look for is a bunch of different things. This is the Bell-Ambrosio display that many of us are familiar with. And as during Dr. Trattler's lecture, he said, what you want to do is look at this red line and see, is it in the middle? Is it above? Is it below? And here, there is a little spot here, and we're seeing we're getting towards the lower end of normal. But what else might we do here? Anybody? What else might you want to see? Another imaging modality that might help you?
Is Christine Shea on the line, or Pooja Jairam? Do you want to give any your input here?
That's okay. We'll move on here. Basically, another thing that I found very, very helpful is really to do epithelial mapping. And epithelial thickness mapping, which had been popularized initially by Dr. Einstein, is really extremely helpful because you could see with your epithelial thickness mapping if this is something that is thickening over your thinnest area of pachymetry, in which case you may have a dry eye issue, or whether you have thinning over it, in which case it's keratoconus. And here, this is really a pretty normal map. There isn't specific thinning, and so that previous patient that I showed you may just have been a little bit of dry eye. When we do a deeper dive here and we take a look, you're not really seeing a specific area of thinning that correlates to the inferior steepening. And so this is something that will probably resolve. So this is to see if you were paying attention before. This is courtesy of Drs. Heckman and Dr. Ralph Chu. This is a patient who presents to you for laser vision correction, and the question is, do they have early keratoconus? We're looking at the K-max here, the thinning, and this is their preoperative prescription. Nothing that exciting. And this is where, when we look at epithelial mapping, and again, I'll go through these rather quickly since Dr. Trattler also showed these slides. This is courtesy of Dr. Trattler. When you look at an epithelial thickness profile with keratoconus, you're going to see thinning over the apex. You're going to see this donut-like. You'll see it's kind of like a donut there. Normal, what you see is not this donut type of shape. And if you do have some thickening inferiorly, then that can mean some dry eye. And this is just showing that this corresponds with a thick area rather than a thin area. And so you could think this may in fact be a dry eye. Do some dry eye management, bring the patient back. And this talks about epithelial remodeling. And when we talk about epithelial remodeling after a myopic treatment, you can see that there's a thicker area of epithelium. After a hyperopic treatment, The thickening is in more of the periphery because that in fact is where the ablation was. And with ectasia or keratoconus, which is essentially the same thing, you're going to get thinning of the epithelium over the area of ectasia. And so that's really important when we're trying to think, is this keratoconus, is it not, is it ectasia, is it not? What else might be going on? Really take a look at your epithelial mapping, and that can be extremely helpful. Ocular surface disease, again, initially this is preoperatively, and this is a slide courtesy of Dr. Trattler, and after 2.5 months of therapy, you could see that that inferior steepening resolved. After another couple of months, it will be interesting to see what would happen with that other eye as well. So moving on out of the topography and tomography, of which we've had several lectures. This is an example, okay, here's the clinical photo. This is an example of which of the following conditions. A, epithelial ingrowth, B, macrostria, C, infectious keratitis, D, CTK, or E, DLK.
Fantastic. So we have with us third-year resident, Dr. Pooja Jairam. Dr. Jairam, do your best in answering this question, if you will.
Hi, I'm actually a medical student, but I'm happy to try to give this a shot.
Well, you're on, so do your best,
Okay, so what it appears, I mean, it definitely doesn't seem like infectious keratitis or a central toxic keratopathy, and I don't really see any macrostriae evident.
And why did you say it's not infectious keratitis?
Because I think that you would be able to see like more of a degeneration perhaps, or like a change in the surface, which I don't really see.
Okay. Excellent.
And I don't, a diffuse lamellar keratitis, I'm not entirely sure what that would look like. So either A or E.
Great, that's excellent. Well, you notice here that there's a relatively white, quiet eye, and so that's another thing that bodes against having infectious keratitis. You're right, there's not large macrostriae. We'll be showing, and you had A or E, and so those are both excellent choices. The answer is A. This is epithelial ingrowth, and this is actually a patient of mine that I did SMILE on, and 6 weeks later I noticed this little area of epithelial ingrowth, or I guess you could call it really epithelial implantation, because I probably put some epithelial cells in there inadvertently when I was doing some rinsing. Here is a case of epithelial ingrowth, and that we typically see after LASIK. Here's the edge of the LASIK flap, and what can happen is, especially if the patient rubs their eye, this can even happen years later, you can get a little bit of ingrowth, these little epithelial cells that can come in. And so treatment, this is a real case. This is a 30-year-old woman. She's 6 weeks after SMILE. She has an uncorrected vision of 20/25, and that's her best corrected vision. And you can see here's the tomography up here. And is this someone you would treat or observe? Who would like to answer?
So do we have Dr. Pedro Ivan Navarro and Dr. Peyton Nitrar on the line?
Hello, this is Peyton.
Hi, Dr. Peyton. Thank you so much for being with us today. Would you be able to give us your pearls of wisdom on this case?
Sure, I've experienced this twice myself with an epithelial implant. And yeah, I think if patients not satisfied with their vision, then certainly removing it is indicated there. If they're satisfied with their vision, you could watch, you could YAG, use the YAG laser for this. That might help with this very small amount that's there, but it's very central. So I'd be concerned that that's significant to the patient's vision, but they do have a say-so and those options.
Great. Well, in this particular case, the patient was not satisfied with her vision because it was in fact central, and she noticed a difference in the quality of vision between her eyes. The other eye was 20/20 and had no epithelial implantation. And so what I did is I went in, this was about 8 weeks later, I went in, I was able to get into the smile pocket, and I just removed that little nest of epithelial cells. You could see the tomography after, and her uncorrected vision improved to 20/20 minus, and most importantly, she's 20 over happy. Not all epithelial ingrowth requires treatment. If you see something like this, and this is post-LASIK as opposed to the case that I showed post-SMILE where I had epithelial implantation, if you have an area that's in the periphery, if you see a demarcation line, they have good vision, they are not unhappy, then you can just watch those, and they can be around for months and months and months. And I used to go in and remove them, but they can come back, and I have to glue a flap. But knowing if you see if it's peripheral, it's not bothering the patient, and there's a demarcation line, then this is something that can just be observed. Okay, next question. This is an example of which of the following? A, epi ingrowth, B, macrostria, C, infectious keratitis, D, CTK, or E, DLK.
Okay, so we've got, this will be our last question for the segment, so no pressure, but Dr. Ritesh Kotecha, will you give us your best guess on this one? Dr. Ritesh, Dr. Ralph Pinati, are you there? And Dr. Raj Shaker Paul. What about Dr. Madeline Yehia? Dr. Madeline? I know some have messaged that their internet connection is not so strong. Dr. Sandeep Kataria, are you able to chime in and give us your best answer on this question?
Yes, I think it's E, it's DLK. Hello?
Yes. Thank you, Dr. Kataria. Thank you.
Yes, it is DLK. And these are looking at stages of DLK. Just in the interest of time, we'll go through them just briefly. You can have a stage 1 to 2 DLK. This is a more advanced DLK here. It's more diffuse. And then you can have the stage 4 DLK, which is the more concerning. What I showed you was more of a stage 1. DLK etiology or include epidefects, meibomium secretions, and most importantly, endotoxin from sterilization of instruments, which has been shown, many papers on that. A treatment or steroids, and more steroids. I'm pretty aggressive when I see DLK, even in an early stage. I treat either with predacetate or Durezol every 1 to 2 hours. I also give a PO steroid. I do 40 milligrams for 5 days and then 20 for a few days, or you can use a Medrol dose pack if you prefer. And when seen after SMILE, the interesting thing is if you see DLK after SMILE, it doesn't necessarily look like that. It can be patchy and what they call a focal DLK. And so just to be aware that if you're talking about after SMILE versus after LASIK, it may have a slightly different appearance there. When to worry? You worry when you start to see, in the case of LASIK, flap thinning or necrosis or lack of control of inflammation. And in this case, you want to go in and rinse it out. In the case of SMILE, if you start to see a DLK that has more than just a couple of little focal areas of DLK that almost look like SEIs, that's when more than just a couple of those that are not responding to steroids, you want to go in also earlier and just rinse it out. Okay. And so if that's, I think, Ashiyana, that's all that we have time for. Is that correct?
Audrey, thank you so much. Can you, I can't leave you without asking the question about your case of refractive surprise and any clinical pearls that you can share with us.
I would say that one of the biggest clinical, I showed, the case that I showed was my case of epi-implantation after SMILE, where that was a little bit of a refractive surprise, and then removing it, you could see how nicely that resolved. I'd say that there, you should really see what you're facile with in terms of refractive surgery. What I tell patients when I am looking at them for laser vision correction is that PRK, LASIK, and SMILE, whether we look 6 months, 1 year, 5 years, 10 years, especially 1, 5, and 10 years, there's no difference really among them, and they're all excellent treatment options. And it really depends on what the patient's needs are, what their refractive error is, of course, and you want to really match the best technology with the patient.
Thank you so much. Thank you, Dr. Rostov, for being here with us. So the next speaker is Dr. Soosan Jacob. Dr. Jacob has a vast CV. Even in her super brief CV, it's like an essay, Soosan. So she is the Director-in-Chief of Dr. Agarwal's Refractive and Cornea Foundation and Senior Consultant, Cataract and Glaucoma Services of Dr. Agarwal's group of eye hospitals based out of Chennai, India, but spans throughout India and Africa. She's a noted speaker widely for her innovative techniques and management of complex surgical scenarios. She has authored more than 100 peer-reviewed publications, more than 200 chapters in 34 textbooks, and is the editor for 17 ophthalmology textbooks and reviewer for many prestigious journals. She has been the recipient of many, many, many international awards, including the Journal of Refractive Surgery Wearing Medal for Editorial Excellence, International Society of Refractive Surgery, Kritzinger Memorial Award, Innovators Award by Connecticut Society of Eye Physicians, European Society of Cataract and Refractive Surgery, John Hennahan Award for Young Ophthalmologists, American Academy of Ophthalmology International Ophthalmologist Education Award, AAO International Scholar Award, AAO Achievement Award, and many, many more. But one thing I didn't see on this list, Soosan, was that you're also part of the top 40 under 40. Am I correct? You were top 40 under 40. This woman is just brilliant. I mean, I have worked with her very, very closely. I've learned a lot from her. And we've had so much fun together. So beyond what you see in a resume, this woman is, I mean, everything in a nutshell. So I am so honored. We all are, Dr. Soosan Jacob, for being with us today. So without further ado, she's going to take us through SMILE and CARES.
Thank you. Thanks so much, Ashiyana, for that very nice introduction. I am just like, if you can you see my screen and can you hear me?
Yes.
Great. Okay. All right. So as we're short of time, I think I'll have to go a little fast. Excuse me. I'm going to talk about SMILE first, just for the residents and the fellows. So we know that SMILE is one of the many cornea-based refractive surgeries that are available. And the difference is that it is flapless and it is all femtosecond laser, and it is done as a single step. If you look at SMILE, basically what you're doing is having a femtosecond laser cut the cap cut and the lenticular cut. And then there's a small incision, which is only a 2 millimeter incision that you see there. And then you go in and dissect manually. both the anterior and the posterior sides of the lenticule, and you bring this lenticule out, and that lenticule is bringing that out is what corrects the refractive error for the patient. So, sorry. The difference in smile is that there's no flap. So obviously there are no flap complications, like striae dislocations. Epithelial ingrowth is much more rarer, but as Audrey just shown, as I'll be showing later, it is possible. You get better biomechanical stability, and we'll discuss about that a little bit more, and also there's dry eyes, among some of the other advantages. So why do you have better corneal biomechanics with smile? That's because we all know that the anterior cornea is stronger, and and also vertical cuts on the cornea weaken it more than horizontal cuts do. So smile has less of a vertical cut than a flap. A flap has approximately 22 millimeter length, whereas the smile has just a 2 millimeter incision, which goes down vertically. And so your vertical cut is much lesser, and also you are having an intact anterior lamella of varying thicknesses. Generally 120 micron cap is the most commonly used one, and so that intact anterior cornea contributes more to the biomechanical strength. So if you look at this, just to understand the difference between PRK, LASIK, and SMILE, in PRK, you're ablating the strongest part of the cornea, which is the anterior-most layers. In LASIK, you have a flap that's created in the strongest part of the cornea, and that flap we know contributes nothing to the biomechanical strength of the cornea, and then you're ablating again in the anterior layers. Whereas what SMILE does is you have an intact anterior stroma, you have a lenticule that comes below that, and then you have posterior residual stroma. So now there are lots of studies that have been done on the biomechanics of post-SMILE corneas, and there have been various reports. Some of them say that you do get a generally softer cornea after LASIK than SMILE, but then some say that it depends also on the power corrected, with higher corrections being more significant, causing a greater significance in the difference between SMILE and LASIK biomechanics. And some studies say that there's not too much significance in the biomechanical strength in lower power corrections. There have been recent studies that have been done with Corvids, which say that intraoperatively there is a difference in the biomechanics, but postoperatively that comes down. There have been studies again on which compare SMILE with LASIK, which say that SMILE, again, the difference becomes comparable on long term, whereas in the short term, the SMILE is superior. There's been studies, again, a very recent study, 29, which says that SMILE is superior to femtosecond LASIK and LASIK, while it's comparable to FLEX and PRK or LASIK based on studies on aura in the biomechanical strength. There have also been studies done using ex vivo corneal biomechanical assessment, which says that SMILE is superior, which is basically corneal extensiometry, just like you study for cross-linking, which is basically taking strips of cornea and assessing it. You've got finite element 3D models of stress, which say which is a study by Cynthia Roberts, which was published in 2014, and it said that SMILE preserves a biomechanical strength which is equal to that in an untreated cornea. And then you've also got mathematical models by Dan Reinstein, which says that again, stromal zenith is better after SMILE. So I would say the jury is still out. Basically, the general consideration is that you can remove a larger amount of refractive error with SMILE, still leaving the cornea with an equivalent amount of corneal strength. The other big advantage of SMILE is less dry eyes, and I think there's not too much controversy surrounding this. SMILE does disrupt less anterior nerve plexi, and therefore, since there's just that small one side cut of 2 millimeters, so the LASIK cut goes all around and it cuts all these nerve plexuses fibers which are coming in, whereas with SMILE you have only a few of them cut, and so your dry eye is much less and the corneal sensation recovers much faster. So this is a study that was published in 2016, which showed that SMILE did have faster recovery and a better recovery of corneal sensitivity as compared to FLEX. And you can see these corneal nerve fibers, the subbasal nerve plexus, which was already visible by 1 month post SMILE, and in LASIK it had not yet regenerated. So there are a lot of advantages in SMILE, but in terms of efficacy, it's considered to be very close to and equivalent to LASIK. It has been found to be effective and safe for correcting high astigmatism, but some undercorrection is noticed. But then, if both for LASIK and for SMILE, you do need nomograms because high astigmatism is undercorrected after both the procedures. One of the other advantages that SMILE has is that it is performed in a closed system, so environmental factors which play a very significant role in excimer laser, they're all eliminated from the process of SMILE. So your tissue hydration, your humidity in the Lasix chamber, all these things do not have any significance on the final outcome. And smile is also been shown to be stable in the long term, with stability starting by as early as 1 week post-op, and centration wise also it's shown to be effective. But when we've talked about all this, how about post-operative complications? What are the kind of post-operative complications that you can have? Suction loss, as in all the femtosecond laser procedures, can happen here too, and you can proceed in all the scenarios except only one, when the lenticular cut is more than 10%, in which case you go on to a flap plus femtoLASIK. So you can just do a redock and cut again in all situations except one. So here's another, I'm sorry, that's the same video. The other thing that can happen is black spots, which are basically uncut areas, and these areas can become difficult to dissect. As you can see here, the dissection proceeds smoothly in all other areas, except when you go to the posterior dissection, you'll see that the area that's exactly corresponding to that black spot is difficult to dissect. So that's another thing that can cause irregular astigmatism. You can have torn lenticules, as you can see there. That was again a suction loss, and you can see that patterned applanation, which led on to difficult dissection. And I'm going to jump here the video, but you can see that you can get these torn irregular lenticles, which can again lead to irregular astigmatism. So this is Ashiyana, one of my take-home points. Basically, the white ring sign, which I had published in JCRS, and this is very important to know which plane of dissection you're doing, the anterior plane or the posterior plane. So the anterior plane always should be dissected before the posterior plane, and the way to differentiate it is very simple. It's just by, and I think you're co-author on this paper, it's just by finding out the white ring, which is a lenticular side cut, and its relation to the instrument. So your white ring above the instrument implies that you're doing posterior dissection, and when the white ring is above, you're doing posterior dissection. When the instrument is above, you're doing anterior dissection. So that's a simple way to find it out. The other paper that I published was sequential segmental lenticular side cut dissection, which again is for thin lenticules. When you're doing very thin parts, one of the problem is that the smile lenticule can tear if you're not careful. So it's important to maintain connection on either side, and for that you dissect the all three parts with very small movements. And I'll just jump through that video as well. So this is how you dissect very thin lenticules, or one of the ways. There have been many ways described. So you make small cuts in the periphery alone, leaving the two sides connected, and then you go and do the two sides in last, and that helps keep the smile lenticule in place and prevents lenticular tears. You can have torn caps, as seen here, and this is especially a difficult case because the anterior dissection was not done prior to the posterior dissection, and you can see how dissection can become extremely difficult. I must add a disclaimer here that many of these videos are not mine. I think I should say that, but these are beautiful teaching videos. Here's a torn lenticule, and you know that you can go back and get it and place them both together to make sure that you've got the entire lenticule out. Epithelial ingrowth, which Audrey has just shown, is also possible after smile. And I've done here a circle procedure and opened up that cap just as a LASIK flap is, lifted up that part of the cap and removed the ingrowth. And then of course, yeah, I think that kind of finishes my talk on smile. Do I have time to go for this as well? Cares as well, Ashiyana? Okay. Hello. Am I still on?
Yes, Soosan. I mean, we cannot leave the topic without doing a couple of minutes on cares.
Okay.
So for all the participants that are there,
okay,
you're getting a bonus. We're going to stay on for a few more minutes past 10. So forgive us, but this is an opportunity of a lifetime to have all these wonderful speakers with us. So we're going to continue on.
Okay, so CARES is a procedure that I described, and the acronym stands for corneal allogenic intrastromal ring segments. I must say I have a patent pending for shaped corneal segments and the devices and processes used to manufacture them. The reason I thought of this procedure was because I was doing intacts and I would see all these complications happening post-intact. This is a patient who had segment migration and actually moving post-operatively in the long term as well as in the short term. Sometimes it happens. You can see it's overriding each other. you can have sometimes necrosis of the overlying cornea and melts of the overlying cornea, having to sometimes remove it, and even leading on to infectious keratitis and therapeutic keratoplasties and so on and so forth. So there's been up to a 30% incidence of complications reported with Intacs and or Kera rings or any of the other synthetic intrastromal rings. And the reason behind that is just because cornea is not the best place for putting synthetic substances. I think we all know that secondary to the synthetic corneal inlays that were there, and then some of them were withdrawn, and also the complications that keratoconus surgeons do frequently see with synthetic segments. So this was my concept. This is a double-bladed trephine. It's basically two concentric rings, one within the other, two concentric blades. And I use this to punch out this ring of stromal tissue from a donor corneoscleral rim. And that is the ring of tissue that can be got. And I think the next video is going to show this to you in better detail. Here, it's important to remove all the epithelium from the donor corneoscleral rim as well as all the endothelium, so that what you're finally left with is only pure stroma. Again, that's the trephine scene with the two blades. You go ahead and punch it, and you remove the outer and inner parts of the donor rim, and you get just this bit of tissue. So this is basically, these are just cataract instruments that I modified to make it easier to implant this. And there's a femtosecond laser dissector channel that has already been made in the keratoconic patient's eye. You can see that it's really easy to implant. This is a question that I'm always asked. Is it difficult to implant? No, it is really easy. So you can see me implanting the segments on both the sides. Trim it to the desired configuration. I've made entry points on both the sides, though I've also done a couple of patients with just one single entry incision, and you can follow up with the cross-linking or not, depending on the patient characteristics. These are some of the post-op images, and you can see this is a single segment cares which is done. These are two segments, one superior and one inferior, and this is a cross-section of the segment seen inside. And one thing you'll note is that it's much more superficially placed than an Intacs. Intacs would go at about 80% depth, because if you don't put it there, your chances of those complications happening are much, much, much higher. So you need to have so much of stromal tissue above Intacs. But in case of cares, you don't have to, because it's just allogenic human stromal tissue. So you can put it more superficially and not have any risk of complications. We already discussed this slide, but other thing I would like to add is that synthetic segments by default cannot be implanted in very thin or very steep corneas because of the problem of melts and necrosis increasing manifold. So they have to be implanted deep, whereas in these natural implants, you can put them in mild cases, you can put them in early cases, but at the same time, you can also put them in advanced cases because it doesn't have the problem of corneal melts and necrosis. And this is an interesting video, which is basically cares being used as a treatment for synthetic segment related corneal melt. You can see that that's the melt of an Intacs. I'm preparing this care segment, and I'll jump through this video a little bit. That's the melt seen there, and these melts are always more extensive than they originally appear because there's just loose epithelium over it. So the actual extent of the melt is much more, and you can see that being demonstrated there when once the overlying epithelium is removed. This Intacs obviously needs to be removed, and I've done that. And once this is removed, what I do is I place that care segment over this area of melt just to see how much I need to fill that tissue gap or the tissue defect. And once I mark that, I take it in, cut it to the desired dimensions, and just put it in there. So once I've done that, I put anchoring sutures on both ends, and I'll again jump a little bit, anchoring sutures on both ends. And these are bridging sutures that don't pass through the segment, but just bridge over the segments in order to hold it in place in the post-operative period. And I put 3 bridging sutures, and then I also put some fibrin glue. That's not a must. I had it, so I put it, and then put a bandage contact lens on top of the eye. And here's the post-operative. I don't have the, I took some slides, gathered some slides together from a much larger presentation. I don't have that, but basically the post-operative appearance, it just healed together. This is somewhat in the post-op period, but after that, after suture removal, you could see an eye with an Intacs on one side and a cares on the other side. So here's some examples of changes in topography which can be brought about by cares. This is post-op, this is pre-op, and you can see the degree of flattening in the difference map with a single segment. Here's another one, again a single segment placed, and you can see the amount of flattening even up to 14 diopters, and the amount of degree of keratoconus becoming much more milder. here's an example of a patient, and I don't know if I'll be able to zoom this up. I don't think so. But basically, it was a -7 diopter cylinder, 612, improving to a -2 sphere and a -2 cylinder, 6/9, with these care segments put here. And you can see that the cylinder has decreased a lot. There's been a flattening here and in the opposite axis, which brings down the cylinder from -7 to -2, and the uncorrected has improved from 21/20 to 20/30. The patient was so happy that he underwent cares in the other eye as well, which was a very small refractive error to start with, -1 sphere with -1 cylinder. I think it was 6/6, and it came down to -0.5, -0.5 with 6/6. Reason I put this slide was because just to show the difference in thickness of the segments. With that, you can actually adjust it according to the difference in the degree of severity of the keratoconus. So more severe keratoconus, you put thicker segments, and you can see you can elicit greater response, and you put thinner segments and you get less response. The left eye patient improved from 20/40 part to 20/20 uncorrected. And again, this was a patient where otherwise I would have done a DALC, and I just did cares instead and could avoid cares with, of course, cross-linking, could avoid a DALC, and I got even up to 18-20 diopters of flattening. I think that this would be my last slide. There's the anti-segment OCT of the segments. These are the light microscopic images of the segment. And I'll finish with that. Thank you so much, Ashiyana, for this great show that you're doing. I really enjoyed it thoroughly.
Soosan, thank you so much. There's a couple of questions for you. The question is, what depth do you put cares in? And the second question is, what is the tree find that you use?
The depth I put is 50%. That gives me beautiful results, and also because it's allogenic tissue, I'm not worried, as I said earlier, about stromal melts. So I can put it much shallower than intact and thereby get a much better effect. The other thing, the other question was about the Trefine. The Trefine has been designed by me. The Trefine has been designed by me, and it's manufactured for me by an Indian company, Madhu Surgicals. If anybody is interested, I'd be happy to put you in contact with them and also help guide you in doing your initial procedures.
You're a rock star, Soosan. Thank you so much for that. And we are, before ASCRS was made virtual, we were going to do a live Smile What Then course, and hopefully at the AAO as well. We'll see where COVID takes us in the days to come. But Soosan has done perhaps some of the largest number of smile cases in the world. So we're honored to have you. Now, those that are talking, if you can kindly mute,
what kind do you want?
it would be great.
Oh, I'll put it in this thing.
It doesn't matter. It can do either.
Okay, well, I'll try it.
So we have next with us Dr. Suvira Jain, who will be giving us 20 happy diagnosis and management multiple choice questions. And we're rounding up with her, a person who has done over 86,000 phacoemulsification cataract surgeries in her life. She has taught over 8,000 doctors and has run a successful phaco school since 2005. She's been a practicing refractive and cataract surgeon since the past 22 years. I can go on and on about her. And she still looks like she's no more than 18 years old. I just don't understand how that's possible. I have learned a significant amount from her, and she is indeed a fantastic teacher. So I'm looking forward to learning from her today. Dr. Suvira Jain, if you can take over.
I hope I can do justice and keep the attention of those who are clearly extremely tired already. But let's just go. Let's see how we go. Just a minute. Just start with my first slide. That's it. And full screen. Thank you. Yeah, that's it. That's good. That's good. Thank you, Jerry. Are we on? Can you see? Yes?
Absolutely. Very clear.
All right. So successful surgery is not as much about just having a perfect surgical end result, but equally important is also having a satisfied patient. So I'd like to share with you a few case scenarios of patients who were dissatisfied following cataract surgery, and I'd like to discuss the way in which they were evaluated, managed, a few concepts in some quick case-based scenarios, and here's case one. So we have a patient who presents to us who's had LASIK surgery done 15 years ago. Yes, he presents now with a history of diminished vision in the right eye for about 6 months duration. On examination, you see both eyes LASIK done, looks largely okay, and the right eye shows a nucleus sclerosis grade 2. The patient then opts for a phacoemulsification surgery. He undergoes an uneventful phacoemulsification with an extended depth of focus IOL implantation. But at the end of surgery, he's unhappy with the quality of vision, complains of glare, double vision halos. So here's question number 1. What could be all the possible causes of dissatisfaction in a patient who's had LASIK done in the past, who now undergoes phacoemulsification with an EDOF IOL implantation? Could it be A, an error in IOL power calculation resulting in an improper selection of the IOL? Could it be LASIK itself, which was done 15 years ago, which has induced significant high order aberrations and a reduced contrast? C, could it be suboptimal intermediate or near vision, leaving the patient dissatisfied? Or finally, could it be D, all of the above?
Will you give us your best answer on this question?
I don't see.
Dr. Ritesh Kotecha. And we also have Dr. Raphael Penititi, as well as Dr. Julian Torby. Dr. Raphael, Dr. Julian, Dr. Ritesh.
Hi, this is Julian. I would say D, all of the above.
Perfect.
Thank you.
That is the correct answer, because when you've had a LASIK done, the fixed relationship between the cornea, the anterior and the posterior surface of the cornea is often altered, thereby making it sometimes difficult to get the correct IOL power. We don't know unless we've done an aberrometry as to whether the LASIK itself has induced significant aberrations. We don't know whether the extended depth of focus IOL is actually able to give that quality of intermediate and near vision. So yes, the answer is all of the above. But let's see what we actually had in this patient. When we looked at the axial curvature map, we actually found that the patient had a decentered ablation. When we looked at the Chang analysis, you could see in the lower left image of the cornea that there is a significant corneal astigmatism, probably which was left uncorrected. But in addition to that, he has significant trefoil, coma, and spherical aberration, secondary astigmatism. The wavefront in the CT summary, again, if you look at the high order aberration profile in this patient, the corneal high order aberrations are 0.277, which is a little more. You want it to be less than or equal to about 0.150. The lower right bottom, you can see the inferior superior axial power at 6 millimeters is actually 2.4 diopters, which should not be more than 1.2 diopters. Now, obviously, this all tells you that the cornea is obviously quite fired. There are significant high order aberrations internal as a result of the lenticular changes. Looking at the E chart, you can see that the overall E in the top middle picture shows that despite best glasses, vision is fired. Now, on the top left, the E looks finely distorted, but that is due to the induced aberrations because of the lens, which would go when you do the cataract surgery and remove this lens. But look at this. When you look at the cornea, the quality of vision of the best cornea with the best corrected glasses taking care of that astigmatism, which we saw in the previous slides, cannot account for improvement in the quality of vision. Okay. Following this, if you look at the MTF curves as well, you can see that at 10 cycles per degree, the area under the curve is it's actually crossing the red box, which means even though the overall contrast is reduced, the cataract itself is also reducing the contrast sensitivity. The cornea itself, with significant higher aberrations, can result in a further reduction in the contrast. And the DLI shows a significant a figure of 6.1, which is as a result of the cataract as well as because of the corneal aberrations. So even though all of the above is the correct answer, in our particular case, it was LASIK-induced significant high-order aberrations and a reduced contrast. The just pointer I'd like to tell you regarding contrast sensitivity is that when we move towards premium IOLs and when we are using lenses that are trifocal lenses or EDOF lenses or multifocal lenses, we're distributing the light energy going in for near and distance. And even though these lenses we are able to buy depth of focus for near. We are paying with the currency of contrast, and that is important to be able to evaluate in our clinical practices. One way of doing it is on an aberrometry, looking at the MTF curve. You need to ideally have a curve that goes like this, where the area under the curve is significant. You should not be crossing the 40% at 10 cycles per degree. The other way in which is you can actually go ahead and get one of these contrast sensitivity charts. They're not so difficult. It's just that we don't end up using them, so we don't know about them. All this, we use the mass contrast sensitivity chart in our center, wherein the ambient illumination is set at between 260 and 270 luxes by the help of a lux meter and getting the correct illumination. And then with the reading glasses in place, the surgeon then reads 3 charts, one for the right eye, one for the left eye, and one for, which is binocular. And he goes from left to right, top to bottom, and the letters keep reducing in the overall contrast. And he gets to that particular letter that he's able to read correctly. So suppose it was this letter in the center that he reads, which is V, and he's able to read it correctly. It immediately reads off what is the log contrast sensitivity here. Okay, and then based on what the patient has, you can grade it as a significant loss, or it's normal, or whether it's okay for his age. And then again, with the help of a chart given, the log contrast sensitivity can very easily be changed to the contrast sensitivity itself. All right. I come to the second case of the series now. We've got a patient who presented with blurring of vision again in the right eye of just 4 months duration. The patient had nuclear sclerosis grade 3. The patient underwent uneventful phacoemulsification, again opted for an extended depth of focus IOL. This patient is now happy with the quality of vision for distance and has no visual symptoms at night, so he's largely happy. But what he expected to get in terms of his intermediate and near vision, he does not get. Post-operatively, he's unhappy with the quality of vision for intermediate and near. We now come to the question number 2.
The question is going to go to Dr. Madeline Yehia. So Dr. Madeline, if you can just tune in to what Dr. Suvira has asked.
So this is a question which reads like this. How do we evaluate the range of vision for different distances? 1, do you use the Snellen acuity chart? Do you use the Pelley-Robson chart? Do you use the Berry curve, or do you plot the defocus curve? We're waiting for the answer.
Dr. Madeline?
Yeah. I guess it's the defocus curve.
Very good.
Excellent.
Okay, so let's take this further. I'd just like to share and explain this concept to you. The correct answer is correct, Madeline, defocus curve. Now we need to understand a little more about it, and I'll just spend a minute or two explaining this to you. So the defocus curve is a graphic representation of the patient's range of vision. It is possibly the simplest and the best objective method of evaluating the range of vision. It works on the refractive principle that F is equal to 1 by D, where F is the focal length in meters and D is the dioptric power in accommodation. So if the patient sees clearly at 1 meter, it means his eye is exerting 1 diopter of accommodation if we go with the formula F is equal to 1 by D. It also means if a pseudophakic patient sees clearly at 1 meter, his IOL now provides 1 diopter of an add effect. Now, if a patient like this, pseudophakic, who has a 1 diopter add effect in the IOL, is seen clearly at 1 meter, you place a -1 lens into the spectacle frame to his minimum distance correction, whatever it may be. And if he is still able to see clearly, it means that this -1 lens is neutralized by the +1 add of his IOL. So by adding, another way of saying this is, so by adding a -1 lens in spectacle correction, we are checking his vision at 1 meter. Similarly, by progressively adding negative diopter lenses to the spectacle frame, you can now check the vision at all the different distances while the patient is still sitting fixed at the Snellen acuity chart with no other changes. So you add a -1.5, you're checking the vision at 66, at -2, You're checking it at 50, at minus 2.5 at 40, and at minus 3 at 33 centimeters. So the vertical axis, when you plot the defocus curve, is the Snellen acuity. The horizontal axis is the distance at which it is checked. In a monofocal IOL, you'll get good vision at 6 by 6 and a rapidly reducing graph after that showing you that, that there is poor intermediate and near vision. You get a double hump pattern in a multifocal IOL signifying a good visual performance with distance and near with poor vision in the intermediate range. If you put in a EDOF or a trifocal IOL, here in a case like this, you can see that you've got a consistently good visual performance, all for distance, for intermediate, as well as for near. Now, what happened to our patient? He was unhappy with his range of vision for intermediate and near. And if you look very carefully, he's 6 by 6 for distance. Even at 2 meters, he's seeing very well. When you come to 1 meter, he's still holding at 6 by 9. When you come to 66 centimeters, it's still between 6'9" and 6'12". It's indicating that he's got a fairly good range of vision for the intermediate range. And as you come down to 40 centimeters and then 33 centimeters, there seems to be a drop in the vision, signifying that this patient was unhappy because this EDOF IOL was not able to give him very, very good vision for intermediate and near. Okay, so can we come to question 3? Question 3 and 4 are related, so it won't take me long to just finish them. May I, Ashiyana, continue? Yes?
Absolutely, absolutely. So we have Dr. Christine Shea, who is faculty at Vanderbilt. We'll ask her to round it out and do question number 3 and 4.
All right, perfect. So question number 3, this is regarding dysphotopsias. Which of the following relating to dysphotopsias is false? So everything is true except for one, okay? A factor behind positive dysphotopsias is thought to be the high refractive index, square edge intraocular lenses. B, a well-known cause of negative dysphotopsias has been the posterior capsule overlying the nasal IOL. C, IOL exchange and ND YAG laser anterior capsulotomy are possible treatment options in cases of negative dysphotopsias. And D, a fog can be a description of positive dysphotopsia.
I'm going to go with C.
That is, IOL exchange and ND YAG laser anterior capsulotomy are possible treatment options for cases of negative dysphotopsia. Do you believe that this is a wrong answer?
Oh, I'm sorry.
Yeah, that's why.
I think it's B then.
Yes, absolutely right. So the correct answer is B. A well-known cause for negative dysphotopsia has been the anterior capsule, not the posterior capsule overlying the negative IOL. So Jack Holliday stated that positive dysphotopsias is an unwanted light, such as a streak, starburst, flicker, fog, or haze. And negative dysphotopsias is a black line or a crescent in the far periphery of the patient's vision. Now, what you need to understand is that positive dysphotopsias are a phenomena which results is it's just annoying symptoms that the patient gets because of the inherent design of the multifocal IOL. So instant light, when it falls onto the IOL end on and hits against the rings, it causes diffraction of light, which can result in glare and halos. And this is how the negative dysphotopsia works. Light coming from the peripheral visual field, hitting on the incident pupil, passing through the entrance pupil, and then hitting against the square edge of a square edge IOL. If the angle of incidence is more than the critical angle when you move from a denser to a rarer medium, which in this case is lens to the vitreous, it can undergo total internal reflection. So sometimes the light, if the instant angle is more than the critical angle, it undergoes total internal reflection. Now those rays of light that undergo a total internal reflection no longer come and focus on the retinal periphery. And these come on to appear as a gap or a crescent or a shadow in the patient's temporal visual field. And I think the important clinical pearl about dysphotopsias is when we see them in our clinical practice, we need to differentiate those which are just slightly there annoying to disabling. You never know who's going to get it. Glasses do not make them disappear. The end result always could be either just something as little as an extended chair time, or they become okay and they abate over time, or the need to explant the IOL. Never tell the patient he's perfectly okay and that he has 20/20 vision. And explain to him that neuroadaptation is going to take time. It's going to kick in, and the brain is now going to readjust to the rings in the IOL, and he's going to get better. And question number 4 is, for negative dysphotopsias, which of the following has been shown to result in a more prominent shadow width? Is it a larger pupil? Is it a smaller angle kappa? Is it an equibiconvex or a plano-convex IOL shape? Or is it a larger axial distance from the iris to the IOL? Ashiyana?
Yes. So I love to call on Dr. Christine Shea. Why? Because she was my senior Duke Cornea Fellow. So better her than me to answer questions. So I will ask Dr. Christine Shea to round this session up with her best guess.
So I have to be honest, I'm not sure. I have noticed my patients who have larger pupils and a larger axial length to complain of it more, but I actually will have to maybe crowdsource this answer.
Which one? Sorry?
So I see somebody has put C in the comments. Yeah. Mm-hmm.
Okay, that is the correct answer. So the way I would just explain this to you in the slide is that generally it is a smaller pupil that is associated with a more prominent width of the shadow, a larger angle kappa, definitely an equibiconvex or a plano-convex IOL, and the shorter the distance between the iris and the IOL. Other factors is the amount and the extent of the anterior capsule overlying the IOL and the other IOL edge design, material diameter, decentration, tilt, and aspheric surfaces. And this has been shown in this paper as well.
Thank you so much, Dr. Suvira.
Right.
Thank you to all the instructors for being here with us. There's no way to say how immensely grateful I am for each one of you taking out the time in the midst of everything that's going on to be with us. You guys are all awesome. I look up to you, and we all do. And so thank you so much for doing this for us. And to all the participants too, for taking the time out and being with us. The goal of today was to add a little bit of light, love, fun into your world with knowledge. And so I hope we've achieved that goal. May you all remain safe. May you all remain positive in this world of current suffering and pain. And may we add a little bit of light, each one of us, to those around us, wherever we may be, whichever continent we may be in. And I look forward to seeing all of you in person after this is over. So thank you again so much, and have a wonderful day, evening, and night ahead, wherever you may be.